So we unfortunately do not have a quorum today, so we're not gonna be able to do action items like the minutes. So if you do have any corrections or changes to the minutes, those of you who are in attendance, go ahead and let us know, but we're not gonna be able to approve those today. So, any changes or? Also supposed to let people know the audio from the Coos Bay meeting is posted to the board's website if you're interested in listening to it. I thought it was a very good meeting. Hearing no changes to the minutes, we will move on to the liaison updates. So, Brenda, I know the workforce committee is presenting today. Do you have anything to add on top of that?
No, I'll wait for the presentation.
Okay, all right, Dr. Santa?
Yeah, just quickly, the summaries are great in the handout. For HPQMC, they did have some issues in response to the letter, and those are mentioned in the summary, and so we should eventually have that conversation with them about some of the additional questions and all that they had. But that was, I think, a very productive conversation, and they get it, and that was good. Metrics and scoring, it's just, I think, important to note that the 2018 report about performance measures is out and is really very interesting to look at. And they have finished the cycle for 2019. So those incentive measures are chosen. There's significantly fewer than usual, but there's a higher proportion that's transformative. The benchmarks are very interesting. And so while there's fewer measures, I think there's some pretty challenging ones and challenging benchmarks. So, and I think we'll hear about that eventually too. So,
Okay, thank you. And I don't think we have anybody else here for liaison reports. So we'll go to you. Okay.
Thank you, Madam Chair. It's been a quiet week in Lake Wobegon. That's actually not remotely true. We've had a lot going on. Most of it has been in the news around vaping, CCO 2.0, other issues. Just a few things to update you on. First, my apologies that I haven't been here the last couple of meetings between court hearings and legislative session. It's been a little bit tough. But I do want to update you on the one court issue, the ongoing challenges with having patients admitted timely to the state hospital on orders related to their ability to aid and assist in their defense. We've now been in compliance with that order for something like 80 days now, and so I'm confident that we've really restored ourselves to being fully compliant. The really interesting thing is that Senate Bill 24, which passed in the last legislative session, has truly changed the nature of the conversation that's happening at the local level between courts, prosecutors, defense attorneys, and community mental health programs. We had some places where that relationship was working really well, but an awful lot of places where it was not working well to just completely non-existent. And we can see from a decreased inflow of patients to the hospital that, and I went and sat in Judge Nan Waller's courtroom about a month ago just to watch a day's docket and how it gets handled. And things are really, that system is working much better to do a better job of appropriately placing people in community-based restoration when they don't really need a hospital level of care, and then getting people back out into the community when they've been stabilized at the hospital. So there have been some significant improvements in that system. A couple of other things to update you on. We're going to spend a little bit more time on the next agenda item talking about CCO 2.0, but most significantly, all 15 contracts were signed by the CCOs and by the agency yesterday on schedule. There are still remaining pieces of work that the individual CCOs need to do to actuate those contracts going into 2020, but it's a great place to be where we've got everyone signed up. And again, we'll come back and talk more about that. Another just piece of information, I think we'll want to schedule some time in the spring to engage with you more fully, but we're working on launching an agency strategic planning process. This is a process oriented toward what's the agency's strategic plan. So, we've talked a lot about the CCO 2.0 plan, the board's roadmap for health, the state health improvement plan that's being worked on now, and this isn't intended so much to be like sort of another version of that. It's more, given all of the policy things that we have going on, what's the agency itself doing and focusing on? What are our strategic objectives? What are the things that we as an organization need to accomplish? Right now, we've been in a fairly extensive community engagement process that we're really trying to kind of reinvent the way we do community engagement as an agency, following more closely the model that we started using when we dealt with CCO 2.0. What I mean by that is that, kind of a traditional thing is you round up all your list of usual stakeholders and you call their government relations people and you have some kind of a meeting with a board or something like that and call it good. This has really been oriented more toward a much more retail engagement with members of the communities that we serve, and especially members of underserved populations in the communities that we serve, to really get at a fundamental level of what does a healthy Oregon mean for you and your community, and what can we do as an organization to do a better job of delivering that. We've engaged with about 700 people across the state using our community partner program. I'm very happy with the outcome of that. I'm due to receive kind of the distillation of the messages that we've heard in that process, and looking forward to that. What this will then lead to is work that we'll start doing internally to start thinking about what are our strategic objectives, what's the work that we need to do. Two areas that I'm just quite confident will be major themes of work. One is, we're calling it, for lack of a better phrase, talent management. Kind of everything from recruitment and internships and onboarding to staff ongoing development and education to succession planning and all the different components holistically of what do you need to do to have the right people to be able to deliver the right stuff at the right time and in the right place. And the other then is a major and different kind of lift on diversity and equity and inclusion across the agency, really focused on how do we move from talking about health disparities to delivering actual closure of those disparities, very much in line with the same conversation you're having here. And again, we'll come back in the spring, I think, bring you a more detailed presentation on that. Last thing I'd like to do is introduce, Dean, if you'd like to come up, our new health officer and state epidemiologist. You probably recall Katrina Hedberg retired about a month ago. Dean Seidlinger joins us, Dr. Dean Seidlinger joins us from San Diego County, where he was the deputy health officer and the children's health officer. We're delighted to have him. He jumped right in the fray with his very first press conference on, was it day 7 or day 5?
We made it to 9.
To 9 on the vaping issue on Friday, where he did a great job. So I'd like to welcome Dean and ask him maybe to say a word or two.
So happy to be here. As Pat said, I came up from San Diego, though I have been commuting from Oregon for most of the past 10 years. So I don't hold the California piece against me. I think, I came from a large health, housing and social service agency that was integrated, so similar to the Oregon Health Authority model, at least on the health side, and from a county that has 3.4 million people, so a little smaller than the scale, but not a tiny county. So I'm excited to be here, work with a really great team, and did hit the ground running around vaping. Luckily, it's something I knew a little bit about, and we've been working on in California. So we look forward to continuing that work and whatever else comes my way.
Thank you.
I'd just like to welcome people who wear bow ties. I wore them most of my career. I have a bunch, so I may bring them to you in the future.
I bring it on.
I trust people who wear bow ties.
Me too.
Especially doctors.
Especially because most of those doctors are pediatricians, so they hold a special place.
Welcome.
Thank you.
And that concludes my report, unless anyone's got questions about anything I talked about or anything else that is going on.
All right, we shall move on then. Thank
Okay.
you.
Thanks.
Jeremy?
Yeah, no, let me kick it off and I'll probably kick it right back to Pat. So you've got 2 materials in your packet, 2 timelines. The first one, this one, really is just trying to show the road we've been on for 3 years now, frankly, leading up to this point of really kicking off implementation of CCO 2.0. It really started back with the Health Policy Board's first round of listening sessions in 2016, moving into new leadership team within OHA, and it's deciding to delay procurement for a year, and then we've all lived through this over the last year and a half. So just a reminder of all the many steps that we've gone through for the last several years. The other kind of timeline, this roadmap right here, this is a little shorter, just where we are right now and what the next 6 months look like. So just a reminder on a couple of key milestones, and then I'll kick it over to Pat to provide a couple more details. So beginning in August, we began the readiness review process. Had rules advisory committees to align our rules with the policy direction and what was in contracts. Went through and made final tweaks to contracts based off of feedback and meetings we had with CCOs as well. September 30th, yesterday, was the date for folks to sign contracts, as Pat noted. The next step is really around communications with members. So remember, there's basically two open enrollment periods, or what we're calling member choice periods. The first one's from October 16th to November 17th, and then there's a second one for the first quarter of 2020. So we've started that process with sending postcards to members that will have more than one plan choice within their area. We're only doing that communication with members where there's more than one CCO, and that was based off of feedback that we received from some focus groups we did with members who basically said, if you don't need to communicate with us, don't, because we're usually freaked out that something bad's going to happen. So we're really targeting communication towards those folks who have the opportunity to change or choice between CCOs. We've sent them postcards. Next, we'll be sending them letters, and we're matching members ahead of time based off of behavioral health and primary care providers they've seen over the last 24 months. So they're basically getting a letter saying, based on what we can tell from who you've seen, here's the CCO that we're going to enroll you in. You have basically a month from middle of October to middle of November to make a choice, make a change, and then you'll have another opportunity after the first of the year. So that's the overall kind of timeline where we're at right now. And let me kick it back to Pat. You've got other details to throw in there.
Sure. So a few things to talk about. First, it is kind of almost quaint to remember back 2 years ago when we were supposed to be a year away from signing these contracts, and we recognized pretty quickly that we had a lot of work to do. Though I remember at the time when we were considering the delay, we had a lot of finger wagging of, well, don't just delay to delay. Be sure you do something useful with that time. And I think the staff have done an incredible amount of work over these 2 years now to get to this place. There's also, and again, I think engagement has been one of the biggest pieces that we've done much differently and much more thoroughly than we would have done otherwise, not just in terms of surveys and roadshows and those kinds of things, but things like posting the RFA for public comment before we released it so that people could see what were we going to ask for in terms of qualifications and tell us whether we got that right or not. There's been some discussion lately about sort of whether we've changed the vision of coordinated care organizations, and I want to speak to that just a little bit. And just sort of clearly say, no, we have not changed the vision. If you think of the vision as a CCO is an organization of providers and payers in the community coming together to talk not just about the payment of health and delivery of healthcare, but more broadly, what are the things that are done in a community and the investments that we and others make that deliver the entire triple aim across an entire community, not just for OHP members, and that we provide that entity funding in the form of a global budget, a pool of dollars that can be used as flexibly as possible and that grows at a sustainable, predictable rate. That continues to be the vision of what CCOs are. I think we've gotten maybe a little bit crossways with some folks is that that's not actually what anybody passed into law entirely in its in totality, because we were worried about where we were going to have CCOs everywhere back when we passed the act. Pretty much anybody can be a CCO, and today pretty much anybody is a CCO. We have CCOs that are based on insurance companies, CCOs that really are that community-based model. One is a wholly owned subsidiary of a hospital. Others are the descendants of managed care organizations associated with independent provider associations. They are for-profit and not-for-profit, and more than one are for-profit. And they don't have a global budget because CMS won't waive actuarial soundness. And so we're kind of tied into that backward-looking cost structure, which continues to be a challenge. So the job for OHA, I think, is for us to keep focused on that vision, but then within the structures that we actually have, work to try to deliver the best product that we can for them. Thinking again about the 2-year delay, a lot of the things that you're seeing now as the things that are being finalized as a result of this process were process decisions we had to make going back a year or more ago. Were we going to do a competitive RFP where we would decide how many CCOs were going to be in a region that was winner take all, or were we going to do something less formal? I think this is one of the first places where we talked about being agnostic as to the right number of CCOs, that whoever qualified would get a contract. We also had a CCO landscape that a year ago looked really different than it does today. It seems like a long time ago. It wasn't all that long ago in the spring when all of, as an example, the constituent components of HealthShare filed independent letters of intent to each be their own CCO. Well, so we had to kind of, not knowing that and not knowing where we'd be today, come up with a process and some decisions. I think we've ended up in a pretty good place. We have 2 parts of the state that now have more than one CCO. Portland Metro, of course, goes back to having more than one CCO. It's new in the Lane County area. Southern Oregon more or less looks like it did before, with the exception of the withdrawal of Primary Health, which we did not grant a contract to based on its financial circumstances. But basically, the same issues around multiple CCOs that existed before exist today, and I think it's certain that we'll take a bigger role for helping convene conversations to work through some of those issues, value-based payment structures, non-emergency medical transport, those kinds of things that are best dealt with at a regional sort of a level. We have completed readiness review now and move forward to contract signing. I indicated that we signed those contracts yesterday. There are multiple phases of readiness review, and so we're now into the second phase, and work continues to be done by all of the CCOs to get things nailed down, including final work in some areas on network adequacy. We won't be assigning members to CCOs that don't have a network that's capable of meeting the needs of those members, and so there continues to be negotiation going on between CCOs and providers. We're going to have 2 rounds of member choice, and I want to spend a minute just talking about what that looks like. We early on made a decision that what we needed to do in that process was be completely patient focused or member focused. The idea was to key on the care that the member is already receiving, and make sure that we didn't do anything to disturb that care. And so the methodology for that was to use claims data going back 2 years, looking at behavioral health and physical health, primary care, and see who are they seeing and what CCO is that are those providers associated with. In the super simplest version of that, they've got a behavioral health provider and a primary care provider, and those 2 providers were contracted with CCOA and they moved to CCOB, and so we automatically move the member to CCOB so that they're already lined up with the payer that is paying the providers they see. Obviously, it won't be that simple in all cases, and there may be cases where the behavioral health and primary care providers go different places, or children and adults in a family go different places, and we've got a set of decision points to work through all of those. Always the idea being, what do we do that is the least disruptive to care, and a member not doing anything results in their care not being disturbed to the extent that we can do that. We had toyed with the idea of just a sort of a mass open enrollment where everybody had to tell us what they wanted, and our big fear was that the percentage who wouldn't respond at all would be so high that we'd have kind of chaos in terms of care. Then we also have a continuity of care provision. This is something that we did, it's one of the learnings we took from the family care wind down, and that's that people will be able to continue to see whoever they're seeing for 90 days for physical health, 180 days for behavioral health. Again, so that if someone shows up in January for that appointment that they had scheduled, that doesn't become a point of disruption if for whatever reason they weren't aware of what was going on. First member choice opportunity will be October 16th through November 17th. The idea there is we'll send notice out saying, here's what we've done, here's who we think we've matched you up to. But if you think we got that wrong, then here are different methods, online, phone call, that kind of thing, that you can let us know and we'll move you to a different CCO. Then for the entire first quarter of 2020, for any reason or no reason at all, people will be able to make a change in who their coordinated care organization is as well. So between those two periods, we think we should have that managed. All I think that we've set out a structure that is designed to deal with that appropriately, and kind of, we've thought of a lot of different things that could happen. I think there are still going to be plenty of problems in this process. This is, potentially a few 100,000 people changing their coordinated care organization. And if we get it 90% right, that's still going to be tens of thousands of people that we didn't get right. And I'm not sure we'll get it 90% right. That's really weird.
I know, what is it?
I don't know. But I turn off your mic maybe. At least that way it won't transmit it. So I think there's going to be a degree of chaos that's going to occur through this process. We've added an outside contracted call center to help us with surge capability. Since these aren't determination calls, we don't have to have state employees involved in dealing with those. So we've got that capacity, and now we're working on provider communications to help manage that process. Jeff, what do you want us to do?
If you're calling into the board meeting for a presentation later on the host code, please mute your phone.
I think it's a train going
But I can't tell what's vibrating. Is it the table or? Oh, there
It
you
is,
go.
yeah.
It's because my
Yeah, you
table's
just hold
touching
your
your
hand like
table.
that for the rest of the
Let's see. So that's member transition. In terms of rates have been set for the CCOs, but there is a second rate setting look back process. Once the membership actually sorts out, we'll be able to look back and see who's got what sorts of numbers, what do the risks look like, and make an adjustment to rates to square that up after the fact. So we should be in good shape there. But rates are always challenging, so there will likely be some discussions that come out of that. Let me stop there and see if anyone's got questions at all about where we are on all this.
I have some questions.
Sure.
So when members are told that there's two CCOs, are they going to also get like a list of which providers are signed up for which, or?
They'll get access to that kind of resource. Yeah, they won't get a book of it, but they'll get links to be able to identify that.
Okay. And so are they gonna like have a heads up, hey, your behavioral health is over here and your physical health is over here, and so you've been assigned to this CCO because this provider, or like, I guess what I'm asking is how much information are they gonna get when they get that notification?
Yeah, my understanding, but I'll rely on somebody to text me if I get this wrong, is that they will be told who we've matched them to and why.
The CCO and the provider? Is it gonna be that level of data, like, here's the CCO you're assigned to and here's the provider you're assigned to?
Yeah, no, not quite that. What I think I understand is they'll be told you're assigned to CCO A because of your claims experience with this particular provider or this set of providers.
Okay.
Okay, so that, or because alternatively, your child has been assigned to this CCO because we don't have claims experience for them, but you have claims experience with this provider who's with this CCO, and we're keeping you together as a family,
Okay.
right?
Or if you had mentioned adults and kids might be in different CCOs because of claims experience, so you're assigned to this CCO and your child's assigned to this CCO.
Yeah, that's one of those cases where there are sort of scenarios where you can imagine everyone wants to be with the same CCO
Yeah.
and the same provider, but you can also imagine scenarios where they actually want to be with
Right.
different providers at different places. So we think the best thing we can do there is tell them what's happened and why, and then
Right.
give them these two different opportunities to change that.
I just wasn't sure how much information will be given on that kind of notification.
Yeah, it's some information, but maybe not quite as detailed as the way you framed the question initially.
Okay, all right. And so when you say they'll have access, it's like there'll be a phone number, there'll be a website?
A website.
Okay, all right. Other
Pat, you talked a lot about the disruption for about 200,000 members, and I'm curious how we will identify the provider network adequacy question. So where we've got new or emerging CCOs in markets, or where there's changes in the provider contracting landscape, how will we determine from an OHA perspective where those members will land ultimately? You know?
Right, so a couple of tools for us to be able to use. There are general time and distance standards and different kinds of specialty standards and those kinds of things in CMS regulations, and of course we'll use those. There's also a quantity kind of a standard around, actually I shouldn't say, we have not in Oregon established further standards. We are actually now working to do that. We can look at other standards around the country that states use, although often they're focused on Medicaid-only providers. And so we're trying to do that. Ultimately, we've got some tools available like an enrollment cap that would keep a CCO from growing at a rate that exceeds what we think is its established capacity for providers. We've got formulas available to allocate people across. This is more an issue in Southern Oregon where the geography is kind of weird with different overlaps of different CCOs. But in all these cases, the idea is to make sure that we don't allocate members to a CCO that doesn't have the capacity to be able to see those members. And that's probably the most sensitive question in the Portland metro area. Everywhere else that we're dealing with multiple CCOs, I think is either sort of got the network questions pretty well answered, or it's just a minor reshuffling of existing providers.
Can you speak a little bit about the state's role in arbitration if there's contract concerns?
Sure. So there are two different provisions in law and rule around what we can do to help resolve circumstances, and they're distinguished between whether it's a new CCO forming in an area or a dispute or lack of willingness to contract with an existing CCO. In the case of a new CCO, there's a process where that CCO asks us to identify one or more providers as an essential health provider, I think is the phrase in rule, that the contract with them is necessary for them to be able to successfully get a contract with us. If we make that declaration, then there's basically a requirement that they negotiate in good faith. And that's been generally our position all along, is providers don't need to, there's nothing that says they have to contract with anybody in particular, but what we don't think they can do is say, sorry, we're not going to talk to you at all and enter into any kind of negotiations. There's the ability for us to trigger an arbitration process that occurs, and then ultimately there's a hammer in that case of our denying access to fee-for-service reimbursements for that provider if we think they've failed to negotiate in good faith. A little bit different set of rules if it's an existing CCO that really focus on not needing to make a particular finding about the provider, but moving more directly to mediation, and there's a mediation process for selecting a mediator and all that kind of thing set out in statute. And we are able to help facilitate that process as well.
John?
Yeah. I mean, I think I've made comments in the past. I'm wary of for-profits, and particularly stock-held for-profits. I mean, to some degree, I've felt like transparency really helps, because I think for-profits, to some degree, you can see what they're up to if they have to meet a high bar in terms of transparency. I've wondered how are for-profits going to satisfy our expectations around social determinants, because their primary obligation by law is to their shareholders. It's to their shareholders. It's not to the community, and it's not to social determinants. And it's not to correcting the inequities I think we're going to talk about later that they have played a role in. I mean, I think it's a bit different, and you're absolutely right. I mean, so the for-profit that's a subsidiary of a hospital, well, that's different. How will the community feel about the resources of this for-profit are going to our hospital versus the resources of this for-profit are going to shareholders around the world. I think that's a dilemma that, you're right, hasn't been settled. But
Well, actually it has been settled, right? The legislature 3 different times had a bill to prohibit for-profits from participating in CCOs, and all 3 times declined to do that, and so they've settled that question. So for me, I guess what I've said, I think, is actually the organizational format of a CCO is not that interesting a question going forward. To me, the interesting question is, regardless of their organizational structure, how do we hold them accountable to behave like a CCO, whether they're for-profit or IPA or hospital-based or insurance or anything else? What do we expect them to do, and do we hold them accountable? That gets to the whole long-running conversations we've had about this notion of, do we or don't we hold CCOs accountable? Does the contract have teeth? Do we enforce the contract? And those, I didn't talk about that, but those have been major pieces of what CCO 2.0 has been about, and now has been criticized as an over-regulatory approach to CCOs. But I think that's the answer to the dilemma you pose that I completely agree with, which is, whatever else their motivations are, here's what a CCO is supposed to do day in and day out. Here's what CCO 2.0 looks like day in and day out in terms of social determinants, in terms of behavioral health, in terms of cost containment, in terms of value-based payments, all the rest of what we expect of them. And our job now is to hold them accountable to doing that, no matter how they're organized.
Right. And how can I disagree? The legislature hasn't dealt with this, but it hasn't gone away. And there's a national conversation about the responsibility that organizations have to us, and the difficulties that are going on. And I don't think it's going to go away.
I agree.
So, I think in terms of the readiness review and in terms of the information out to members, we need to keep those issues in mind. I mean, frankly, I wonder if members should be aware this CCO has a legal obligations to its shareholders first. This CCO, its obligation is to the community.
Well,
And
I
let's-
guess the practical answer to that is the communications are in the mail, so we're not going to add that at this stage in this process. But point taken.
Thank you.
I think beyond that also is the question about what community governance really looks like. And I think that's one of the largest questions relative to the larger CCOs or out of community-led CCOs, is how do we ensure that the entire model around it being member-driven and community-owned really is so fundamentally core to the model itself that that's like beyond question, larger systems. And I don't know that we can regulate that unless you have other ideas in terms of how 2.0 is rolling out, that we can somehow ensure that the member's voice is really critical to the way that the direction of the CCO is actually moving in the community itself. Do you have thoughts?
Well, I do think that we've, between statute and contract and your policy recommendations, we have said some things about that in terms of structure, increasing the number of community advisory committee members that are on the boards, those kinds of things. Interesting thing to me is, as I sit there and look across the landscape of who I think, in a sort of a lay sense, does a good job at community governance and community connectedness, and who does a less good job, it doesn't track to for-profit or not-for-profit or organizational structure. I can think of a couple of examples of for-profit organizations that are doing a great job with that structure, and I can think of nonprofits that aren't so good at it. And so I think it really, again, you have to, and of necessity now, we need to sort of move away from the structural issue to the performance issue, and insist on that 2.0 level of performance, regardless of what other accountabilities that organization thinks it might have. And we've got a pretty big hammer with a whole lot of money on the table.
Can you speak a little bit more about, in the areas where there's overlapping CCOs, OHA's role around alignment? So you mentioned non-emergent medical transportation or value-based payments as a way in which the state might engage the CCOs around finding more continuity or consistency across systems.
Mm-hmm.
Can you talk a little bit more about that?
Sure. I think there are topics, and those are two that I cited, where It's pretty clear that a cross-regional approach would be superior to everybody doing kind of their own thing, and in many instances, not only would it be better for us to engage ourselves in that, it's necessary that some kinds of value-based payment structures, I don't think the CCOs legally could go have their own conversation about, hey, how are we going to structure the way we pay providers. I think we actually need to convene a conversation like that. Not to mean that we're going to try to set out everyone's going to do it the same way, but at least at some broad structural definitional kinds of levels, can we help get some agreements in a region that we don't drive the providers batty? And I think that's actually a conversation that can move over into things like PEB and OEB in the marketplace and those kinds of things, because we move the overall system toward more focus on value-based payments. But the idea is for us taking responsibility to be the convener together with the community to have those conversations and work out those structures.
And specifically, I mean, so legislation that passed this session requires CCOs, local hospitals, public health, all to work together on a joint community health assessment and health improvement plan. The contracts require that there be metric alignment if there's multiple CCOs moving to value-based payments, that they're pulling providers in separate directions in terms of quality metrics. So just we'll play a huge convening role in that, but just a couple of specific examples where it's actually required that they work together.
Any other comments?
I think I said this a couple months ago, but it sounds like we're about to communicate we are communicating a very complex message to members. These are folks who are going to have language barriers, lots of other challenges, very busy people with lots of things pulling them in various directions, and all of a sudden they're going to be told by OHA, like, you are now potentially shifting over here, and we think that these are the reasons why you should belong over here. And then we're going to potentially send them to a website. So I'm just very, very concerned about not hearing other communication strategies other than a postcard followed by a link. So I think I heard last time, or two months ago, that there were other strategies, but I'm not hearing those strategies as well.
Yeah, I apologize for oversimplifying that. First, though, the problem you identify is exactly the reason that we decided not to do a sort of an all-comers open enrollment kind of a process, because we thought that was likely to be a challenge in people not responding and then having challenges with care. The written materials we're sending were required by CMS to communicate in writing, so that's a little bit of a challenge. Those are being translated into the 8 most common languages based on the preferred language of communication that people have identified for us. In addition to websites, we've got an 800 number with multi-language capability. And then we're also reaching out to community partner organizations. And we think that actually a lot of what you're talking about is direct connection to organizations that people already deal with and have a trust relationship with, and we'll be able to help navigate through that process. So we're trying to hit multiple channels to try to deal with exactly what you're talking about.
Are there prohibitions of communication from the CCOs to the members?
Yeah, communications need to be approved by us, and sort of the super simple non-lawyer version is they can provide information, but they can't explicitly market. So here are our providers, perfectly fine. Here are our providers, so sign up with us. Can't do that.
And are you had mentioned about the 90-day and 180-day grace period, and I'm assuming that will be sent out to providers, or CCOs will be told to send out to providers, so that somebody doesn't show up and
Right.
the provider says, well, you're not on our list.
Right.
Okay. All right, anything else? All right, thank
Thank you.
you, Jeremy and Pat. So, now that Kirsten's here, we have a quorum. So we're gonna go back and look at the minutes. And I will entertain a motion.
I'll move approval.
Do I have a second?
Second.
All in favor?
Aye.
Opposed? Okay. And then I didn't know if you had anything you wanted to add regarding High Talk for liaison report, or?
No, not at the moment.
Okay. All right, great. Trilby?
Yes. Good morning, everyone. We are now shifting gears to talk to you about the 3 priority areas the board has identified that we have been tracking for you. You have in your packet a visual, which is up on the wall here. Still looking busy. We have made some changes to try to get less detail. And one of the things you'll notice, thanks Jen, one of the things you'll notice is that we don't have the CCO 2.0 activity reflected on this visual anymore. I think there's so much going on with that, and you've heard a lot about it this morning, that we're going to limit ourselves to the 3 priority areas on this visual. What I'd like to do is talk you through these 3 areas and identify 4 or 5 key activities that are going on in each, and then talk to you a little bit about some information that we've added on the flip side of this visual to try to give you some more detail. But starting with the top, this blue area is where we talk about our efforts around cost. And the primary activity that we've been showing you in this area has to do with Senate Bill 889 and the implementation committee that is forming to discuss a healthcare cost benchmark program. And you'll see that those activities are still up here. You'll notice that we're getting close to the launch of the implementation committee. It will hold its first meeting on November 7th here in this building at 1 p.m. And we're all very excited about that. We've been busy working on materials, agendas, and we have interviews coming up for some new staff that will be leading that effort. So the red flags that you'll notice around the implementation committee are periods where we think it's going to be important to either bring you information so that you can review what's going on or actually take some action improving the activity. Your review and approval, your formal review and approval of the implementation committee's recommendations doesn't come until later in 2020, but we'll certainly be bringing you updates once that committee gets underway. And you'll see that underneath the implementation committee is the baseline data analysis going on. We do intend to have a report on cost drivers that will be based on information that we've gathered prior to launching the benchmark, and that report will be coming out toward the end of 2020. So one other related piece is the report on waste, and you'll notice that a bit further down with a dashed line around it. I've mentioned this to the committee members a couple of times. This we see as a real complement to the 889 work, because what this will do is highlight some of the opportunities for savings here in Oregon. There was a report put out in Washington State that received a lot of really favorable attention, and what we're aiming to do is really replicate that analysis for Oregon. The Oregon Health Leadership Council is very interested in this report, and they're partnering with us to produce this report. Where we are with it right now is that Milliman is delivering the data, probably this week or next, up to the Washington group that did the analysis, and they will be running a similar analysis on our data. We'll produce that report and get it out, probably releasing it at the end of this calendar year or the beginning of next. And I think that will really help highlight the importance of the implementation committee and the work on cost here in Oregon. We've added a bar down toward the bottom of this blue area on PEB and OEB. And we thought it was important to keep the board posted on what's going on with their innovation work group, because they're taking some very important actions around cost as well. And really what they're focusing on are the VBP targets for PEB and OEB, as well as recommendations for enhancing the coordinated care model. And they will look at some enhancements to pharmacy management as well. So we'd like to bring you updates from that group as well. And then finally, what we've got at the bottom is the VBP spread and alignment. And this is an area where we look forward to breaking it down into more buckets for you instead of this long continuous bar. And we'll have Chris DeMars coming in to talk to you about what the Transformation Center is putting together in the way of technical assistance to the CCOs for making some real progress toward those VBP targets. So that is most of what's going on up in the cost area. Any questions on that one before I move down into the children's area?
think it's more a question about the board's readiness to receive this body of work and what kind of supports you think we may need in terms of educating ourselves at the right level of detail in order to be most effective to engage it appropriately. Have you given some thoughts to that, like study sessions or additional deeper dive or?
I mean, I think at a high level, the implementation committee is gonna be really just making the program design details. What do we set the target at? What's the data that we need? How do we measure against it? What are the sort of enforcement accountability pieces? What we've talked internally, it'd be great to get your feedback of throughout that process, you know, are there some sessions where we would wanna just help get the board more and more up to speed in terms of what cost drivers are? We're gonna be running a lot of data analysis as part of the implementation committee's work, so we're happy to build those in between now and the end of next year before we turn the program on. So I'll take your question more and more as a comment that that's
Yeah,
something that you're
I think so.
interested in. We'd be happy to build that in.
Yeah, I think in order for this board to really accept the responsibility around this territory, we have some muscle building to develop, so.
Yeah, we definitely talked about, you know, the waste report when that comes out, making sure we get that in front of you all. But like I said, we're pretty actively running data on a weekly basis now, understanding more and more what's driving costs, and we're happy to build in some sessions one way or another with you.
Yeah.
You know, I recall the Baylor session was really helpful
Right,
for me.
like that, yeah.
And I think repeating that or continuing that, you know, the emphasis was this was doable. You know, even in a place like Massachusetts where you have the highest density of healthcare economists in the world probably, is doable. So,
We'd be happy to do that, and we can bring, you know, like I said, there's actually now a lot of different kind of paths of work happening between this race report, the PEB and OEB innovation work group that's looking at cost drivers across those two programs. So we take this back and give some thought on how to do it, but that's just great feedback because we kind of hoping that you would want to stay engaged in this.
Yeah, that's good to hear. I mean, just to give you a tiny bit more detail on PEB and OEB, they are starting to really dig down into what their cost increases are. And cost is the driver for both PEB and OEB, not utilization at this point. And it is outpatient surgery costs. I mean, they can drill down and see that this is what's driving costs significantly across PEB and OEB. They're also seeing some utilization increases around mental health. And then they can break down between PEB and OEB and see that one of the contributors for PEB is also risk scores. And, you know, what's going on with their members in terms of, you know, who's in their pool and what their health scores are. The PEB risk scores are higher than OEB's, and they are increasing at a higher rate. So these are things to dig into. They have the top conditions in terms of what's costing money in OEB, include cancer, arthritis, and for PEB, it's cancer and spinal and back disorders. So this is the kind of information that we're already getting for PEB and OEB, and you know, we're going to be working to bring that to you across markets and really get a sense of what's going on. So yeah, great that people are interested in that, and it might make sense to get Michael Baylett back before his contract ends. All right, so moving on to children. In this policy area, we have added quite a few things. You'll see that the INC application, that is not new, and this is the grant that we've applied to the federal government for. We will be hearing back on that in December with a decision, and I think an encouraging sign is that we did hear from CMS with a long list of questions about our application. So staff have been very busy. There was a short turnaround to get back to them with information on that. And it seems to be a good sign that they're interested in our application and really want to know more about what we'll be able to do. So fingers crossed on that. It could be a really significant grant for us to move that work forward. The next bar is about providing support around children's health complexity. And you all heard in June from our CMO on that, and there's really quite a bit of work going on there. The member reports to the CCOs have been updated with children's health complexity scores. So that was a big step forward in terms of giving them some more detailed information about their young members. And they received this very enthusiastically. So what we're now exploring is whether or not it might be feasible to try to incorporate some of this data into their dashboard reports. But that will be very dependent on staff resources and technical assistance resources for the CCOs. We want to get back in front of you some more information about those technical assistance components if that's of interest to board members. The Oregon Pediatric Improvement Partnership, OPIP, has the technical assistance contract with our Transformation Center. And they are going to be providing a series of briefs on how to use this complexity data and learnings from their work with the CCOs thus far. Would there be interest in us bringing some of that back?
Yes, I think that would be helpful. The health complexity, is this being used as a risk stratification? Is that driving payment or finances or?
No, not at this juncture. It's more to target interventions and to be aware of what is the breakdown among members and what their needs might be and how best to deliver services given the variance across different populations.
Do you think at some point it will be used?
We'll be in year 3 of the CCO contract moving to what we're calling performance-based reward, which is in essence a variable profit margin that we build into the rates where CCOs are decreasing costs overall, that they basically get a financial reward through increased profit. So what we're hoping is these are the types of data that they give the CCOs where they can start getting ahead of that now and start making those interventions. So I don't know that we necessarily tie specifically to children's health, but this is sort of one component of where there's opportunity for them to lower costs.
I guess what I think about though is that in order to address this, it's going to take a certain amount of resources to be able to drop that down. And so if you don't front load it, then I'm not sure how you can take care of that. I guess I always think of, I think it might have been Governor Kitzhaber who had the diagram that showed, you know, this is your cost curve, but in order to drop it, you got to have a little bit of extra to do it.
Yeah.
So while it's helpful, I think, to identify it, I think that if we don't provide something to help get the additional staff or, you know, outreach or whatever, I'm not sure if clinics or CCOs will be able to do that. I guess that's my concern.
We haven't built in some specific additional resources for this. I mean, like I said, we're trying to give a critical glide path to eventually paying them based on performance, but the Inc. grant, the federal grant that we're applying for would provide some of that, but it would be tailored to some specific regions within the state that showed interest.
Okay.
I think you're asking a really good question, Carla, around do we have the mechanisms yet in place, or do we have vision about building them where there's some rate sensitivity relative to the risk stratification of the population being served? So I think that's a little bit different than your answer. And I know that we do that now. I mean, there's lots of, you know, structures to sort of differentiate the population, but not relative perhaps to their social complexity or risk.
We have, so just to be clear, so we have been talking about doing a sort of social risk adjustment, if you will, within rates. We're not there yet, but
Okay.
we have been talking about that. So hopefully these things will come together over the next several years.
And there are places where we do provide resources sort of in isolation for different elements of this complexity. So a little bit of chicken and egg, but part of it is how do you consolidate your understanding about a particular member's multidimensional complexity so that you can identify those resources that already exist in the system and then pair that up with further investments that come through social determinants to try to better target the
And focus
resources
it, yeah.
we have now.
Thank you.
And that could be something that we try to focus on the next time we come back to you to talk about the children's complexity data, is how the CCOs are able to use that data to help them access existing resources and really put together packages that are specifically tailored to their members. Because we'll have some of those learnings by then. As to how
Yeah,
the
it'd be
CCOs
good to couple it with sort of our overall social determinants of health strategies, which there's several of, right, including trying to spread community information exchange, you know, screening tools, things of that nature, you know, learning collaboratives that the Transformation Center will be doing.
Yeah, lots of moving pieces in these areas. And we'll talk a little bit more about some of those as I work my way down here. Okay, so we have this lined up for you to hear about again toward the end of 2020, and it may be that we want to do that even earlier. We can take a look at that. Kindergarten readiness, things are on track with the first 2 kindergarten readiness metrics, and those should be out or finalized in December. And the first 2 are the well child visits in 3rd, 4th, 5th, and 6th years of life, as well as members receiving preventive dental services ages 1 to 5. There's a new bar here on building cross-sector partnerships. We thought it was important to bring to you this really high-level and critical work that's going on that OHA has been very involved with. Pat's been very involved for kids, and this includes both Raise Up Oregon, which sets out an early childhood strategic plan. And this was led by the Early Learning Division and has priorities and strategies from 5 different agencies around early childhood. And then also the Student Success Act, which is really, this historic investment in education here in Oregon. And the work that's going to come from this group, I think, is really going to be a game changer. And I remember Pat said when he was speaking to the CCOs, this is as much a legislative act on health as it is on education. So we're really looking forward to learning more about the priorities as they sift out there and then bringing them back to this group. And thought it was important to reflect this on your activity sheet.
So how do you view that collaboration or partnership?
Oh, Pat, did you want to
Yeah, I
speak to that?
can speak to that. The governor has convened Department of Education, Health Authority, Human Services, and a couple of other agencies to really work collaboratively with ODE on implementation. They've identified sort of 4 categories of funding. Behavioral health is one of those categories, and ODE has been real candid in terms of wanting our support and collaboration with them to help them shape what the requirements are and expectations for that funding stream, so that they aren't going and reinventing some other kind of a system. We're taking advantage of that opportunity to then shape our added resources around intensive in-home supports, behavioral health resources in school-based health centers, and the same resources in schools that don't have health centers, to basically create a kind of a, as non-overlapping as we can, set of investments around mental health for kids. I'm very encouraged by the degree of collaboration that's going on across the agencies, and the governor's office's leadership has been key to that.
Do you see a connection with like trauma-informed care? Because I think one of the gaps that I often saw was both of these sectors had training and work around trauma-informed care, but there was not communication between them related to specific students, patients, and then I'm thinking about the health complexity on top of that.
Mhm.
Like how does, to be able to connect all that, I think could be a real game changer for kids as well as their families.
Yeah, I think it's too early to speak in detail to that, but the whole notion of school systems awareness of ACEs, the ability to cross-pollinate different trauma-informed care structures, and that being a topic in education that is informing their work. I think all those pieces are kind of in play right now, and the first year, it's important to remember this is not like a one-time grant program. This is an ongoing significant increase in baseline funding. And so the first year or 2 may be fairly rocky in terms of some of those connections, but I think we're on the exact right path to really have a true sort of cross-pollination across those areas in a collaborative sense. It's not like anything I've ever experienced in government before, where there's just not a ton of turf kinds of things, and it's a lot of, well, if you're doing that, then I should probably do this kind of conversation.
Yeah, it is.
Yeah, it changes everything.
Okay, so we also have a bar representing the work on the universal home visiting, universal voluntary home visiting. And we're in the process right now of identifying some early adopter communities. The CCO 2.0 Children's Health VBP support and best practice spread, that's something that we could hear more about from Krista Mars when she comes in to talk about VBP generally. And then finally, we have some activity that we're showing you on the Children's Health CCO Measure Performance Update. And we've put some red flags here, thinking that this could be of interest to the board to hear about periodically. There's really a number of measures now that focus on children that the CCOs have been incentivized on beyond the kindergarten readiness work. So if there's interest, we can come back and do a deeper dive on that.
Yeah, right. And I was kind of stunned. I mean, the performance for the foster care stuff is now up in the 80%. I mean, to take a system which has really struggled, and at least the medical piece, to say that more than 80% of all foster children have at least been evaluated, screened. One of the incentive measures that was approved, it's dental, and forgive me, I can't remember the detail, but I was stunned when I saw it will affect 240,000 children. 240,000 children. I mean, the scope, when you look at the numbers, for me, just is really impressive. And I'm sure there's some that we're struggling with that should also, in fairness, be presented. But it's a very powerful story.
Good, all right, so we'll bring some of that back as well. And finally, we can move to the health equity policy priority area. And I've got 5 different things to highlight for you here as well. First, I wanted to mention the Tribal Behavioral Health Review, and that's about 2/3 of the way down. We wanted to bring periodic updates to you all, and I think when we were in Umatilla, this first came up as something of interest to the board. Yeah, so you will be hearing from Julie Johnson in OHA Tribal Affairs. She'll bring regular check-ins and updates to you, and the first will be in December. I also wanted to mention HPQMC. I know Dr. Santa reviewed some of what went on there. I was with Dr. Santa, and we fielded a number of questions, lots of discussion, reaction to the letter that the board sent. The committee is excited about getting some technical assistance from Michael Bailett, the same person that we've engaged around the cost work. And he is a consultant who worked with the committee early on when they were setting up their measures. And he's going to be talking with them about the processes and the criteria that they have and whether they might want to tweak those, reestablish those for innovative measures to really pave the way for some of the metrics that are going to be proposed to them early next year, including the health equity metric coming back to them, as well as some discussion of a social determinant of health metric, which will come a little bit later on. But it was an interesting discussion. I think there are those who feel that the criteria are just fine the way they are, but I think there will be, a lot of conversation about what's going on around the country. Not that anybody has really done this yet, so it's another area where Oregon can be groundbreaking. But there was excitement about having the assistance of an expert and some attention to this, and that'll be launching next month and then continue through to February. They'll also get assistance in working on the core set, and that assistance will be delivered through June. And this is all thanks to a group called State Health Value Strategies in Princeton that's providing us with this TA. So the next thing would be to mention the social determinant of health measure. This is new. We've added this to the equity map just to give you a sense of not only do we have the health equity metric that's been developed and is really poised for another review by HPQMC, but we also have work on a social determinant of health metric and a committee that's being formed around that, and then the results of that work will come back to HPQMC as well. I should mention that on the health equity metric, there have been CCOs who have volunteered and stepped up to pilot data reporting around that metric. That requirement is included in the contract. So we will be learning quite a bit about how that's received by the CCOs and what they're able to provide by way of reporting on progress with that through the contract. Then the SHIP committees, and these are reflected in a couple different areas because they really touch on a lot of the priority areas of the board, but just letting you know that they've all launched, they've all had their first meeting. We'd like to bring back to you updates on the Economic Drivers of Health subcommittee as well as the Institutional Bias subcommittee, and most likely that will come from our colleagues at Public Health. And finally, actually, I think I've covered this already, that the work on the foundational measure, the interpreter measure, the health equity measure, that's all referring to the same body of work, that continues. 8 CCOs have volunteered to help pilot. Any questions in this area?
So later in the meeting, we're going to be having a conversation about health equity and health disparities. Do you think this area takes into consideration health disparities?
I do. I think our work on health disparities fits squarely within this area. And this definition of health equity, which is being brought to you today, is reflected in a bar at the very top, which I neglected to highlight, and I should have. And I know we've had some interesting conversation about the difference between equity and disparity, and I think that'll be a good conversation today. This is an area where measuring disparities is key for us to be doing and reporting on to this committee, and you'll see at the very bottom here, we do have the long ongoing bar reflecting our work on the Real D data collection, which really is fundamental to our ability to track disparities across all the different measures that we've got. And that work is ongoing. We'll continue to report to you any significant progress with it, which all hinges a bit on the integrated eligibility work.
Brenda?
Yeah, I was just going to ask if you could share a little bit more visibility or insight to that work specifically.
Right, and this is where I would come to that.
Yeah, so the integrated eligibility system will is able and will collect Real-D data. We've also made a change to the existing one system that went into effect later than we expected due to a vendor problem. But in the current system, it was possible for someone to skip the entire race, ethnicity, demographics section. Now they can't do that, and they have to go in and actually positively say, I don't want to answer that question. I haven't seen data yet on once that switch occurred, how much decline has dropped, if at all, although I would expect it would have. So we won't have systems barriers. I suspect that we will still have whatever other kinds of barriers are keeping people from being willing to answer those questions. And so I think we're still going to continue to need to do some parallel work outside the system to try to figure out how to get at that data in the face of people's unwillingness to provide it as part of the application process. But when the system rolls live, we'll have that capability.
Yeah, I just think there's so many interesting questions. I mean, take foster care. Let's say there's a day that 95% of foster care children are being appropriately screened. The question will be, is who are the 5% who aren't?
Mm-hmm.
What if the 5% who aren't are of one race or ethnicity? Because the equity definition that we'll talk about has to do with injustice and unequal treatment. It's very different than disparity. So there's lots here.
Yeah, I mean, in my mind, the disparity is the outcome that stems from the injustice.
That's right.
Right. And I mean, it seems to me that if you don't deal with both, you're really not fully dealing with the problem, right?
Well, we'll get into it this afternoon. My take was, so inequity is dealing with that injustice. And so that the measurement system in some way should focus on, have you dealt with that injustice? Is the injustice gone? That if the injustice is gone, the disparity should disappear. But maybe I'm wrong. So the measure, I think, is about the injustice.
We'll get there.
We'll get there.
Yeah, I don't want to preempt that conversation, but it is a fascinating conversation, and I think we're all continuing to learn about the appropriate lens. Just the last thing to highlight for you is the flip side of this, just so you see what we've done here. This isn't an effort to give you a different way to look at all this work. It's a bit overwhelming, there's so much going on in these areas, but here you've got more of a list, things broken down into slightly smaller chunks. And what Jeff's done in the green bars to the right of the chunks is give you a sense of our progress. in these different areas. You know, in some of them, you know, we've pretty much done the launch, on our way. Others are just getting started, but we'll continue to update this to give you a sense of progress in a different way than the flip side. One thing I like about this side is we're able to capture the ongoing work in gray at the bottom, rather than giving you those long continuous bars that aren't so helpful on the timeline. And then we'll keep giving you current status notes at the bottom on each area. So I know this will take a bit of time to digest, but we're always happy to get input on how to improve this reporting. Any other questions about these priority areas?
I like the dashboard. It'd be nice to sort of, you know, make sure that this isn't the only time we'll see it, and then maybe a year later we'll see it again, but also
Yeah.
kind of maybe quarterly or something like that, and kind of get an update from you about progress made.
Okay, yeah, very good. I think we've been coming about every other month or so, is that right, Jeff, with this?
Yeah, I have a very meetings kind of threw off our cadence, but.
Yeah, but making maybe on the quarter more of a report on progress,
Yeah,
emphasizing
putting it
that.
on the calendar for sure.
Yeah, good. Thank you.
All right, so we're running about 10 minutes ahead. So I think what we'll do is go ahead and take a 10-minute break, and we will reconvene at 9:50. So if there is any public testimony, anybody wants to sign up for public testimony, the sign-up sheet's over there. We will do public testimony when we come back at 9:50, and then we'll move into the workforce incentive program. And then after that is defining health equity. So let's take a break. Okay, all right. So if we can have our healthcare workforce group to join us. Jeff Clark, Kurt Stilp, Mark Overbeck, and Joe Sullivan. We need one more chair. And then, I think Brenda, your team is up for this, right?
Yes.
Okay.
I am. It is my pleasure to be the liaison for the Healthcare Workforce Committee. And what I want to say to the board before our esteemed panel shares their insights with us today is what a great committee it is. Carla, you weren't kidding. One of the things, just in my short time of being a liaison with this group, I've noticed the level of thoughtful consideration and deliberation that you all have engaged with the committee members themselves. The degree of engagement, the degree of participation of like hot topic debate from time to time, is really a testament, I think, both to the leadership of the committee, to the staff of OHA, and to the committee members themselves, who deeply, deeply care about the workforce of the state. And so I'm excited to hear the presentation today and help support the team in their work.
Thanks very much, Brenda. We are delighted to be here today. We'd like to speak with you about the background of the committee, make sure that all the board members, including the newer board members, are up to speed about the Healthcare Workforce Committee. Give you a sense of where we are, what we've done, where we've come, some of the good work the committee and happening around workforce in the state. And then also, we very much would like to get your review and decision-making on the committee's recommendations regarding the 2019 to 21 distribution of funds in the Healthcare Provider Incentive Fund, and then, of course, from you, discussion, clarification, and further direction. So why don't we start by introducing ourselves, and then I'll tee it off to Dr. Clark.
Sure. Hello, everybody. Kurt Stilp. I am the Vice Chair of the Healthcare Workforce Committee and Director of the Oregon AHEC, or the Area Health Education Centers, and Associate Professor at OHSU PA program.
Mark Overbeck, Oregon Health Authority, and Director of the Primary Care Office and staff for the Workforce Committee.
Good morning, I'm Jeff Clark. I'm the 2019 chair of the Healthcare Workforce Committee, and I'm a naturopathic physician in private practice in Tualatin, Oregon.
I'm Joe Sullivan. I'm from OHA, and I'm the Healthcare Provider Incentive Coordinator.
Great. Well, it's my opportunity to just remind everybody a little bit of background on the committee. I guess we got slides moving forward here too. This is one of the two initial Oregon Health Policy Board committees that were codified in 2009. And our mission, as we kind of see it, is to attempt to look over the horizon and to anticipate the needs of supply and demand of the state for primary care especially, but behavioral health care and the other healthcare needs that we have going forward. And through the resources that's been given to this board and through our recommendations to attempt to influence that where need is not met, that maybe we can get people to go to places. We'll be talking more about that. Next slide here. So as we just introduced ourselves, this is the leadership for this year. Robin Drybalvis, DO, is not with us today, but she's been previous chair and then vice chair before that. We have 18 members, and we're actually pretty happy with the diversity we have across these different dimensions that are listed up here. So let's see. So next one. The wrong one. It's on the wrong one. Sorry about that. Okay. So these are our current deliverables that we have been working on in recent times. The focus of our presentation today is on how we are proposing the provider incentive funds from the state of Oregon be allocated going forward, as Mark introduced. And then the next slide. These are some of the deliverables that this committee has produced over the years of its existence. I'm currently in my 5th year here, so a number of these things predate myself. All right.
So with all of that, the question is, where are we in 2019 compared with 2011? If the legislature saw fit to create a workforce committee, what has the workforce committee been engaged in? Is Oregon any better off than we were 10 years ago? You could say, well, where we are right now, let's talk about where we are. We know we have increased insurance company, and in fact, the world has changed quite a lot in Oregon in the past 8 years and 10 years since the workforce committee and the board were created. We have increased insurance company. We have increases in the number of providers providing care in the state. We have over 700 patients at primary care homes. We had a largely successful CCO 1.0 effort. You're hearing more about CCO 2.0, including at today's meeting. We've taken a look at how do we determine whether we're successful, where the need is, and we've made changes to the criteria for unmet need. We have our federally designated health professional shortage areas, and those scores largely have trended downward, reflecting the stabilization of the workforce in Oregon, certainly compared with many other states, and a much more robust workforce in some areas of the state, where 10 years ago, 6 years ago, it was deemed impossible to recruit providers, and now there are more than enough providers to take care of the general population. We still have an aging provider workforce. That was a challenge that we had 10 years ago that hasn't gone away. Apparently, people continue to age, even though the Oregon Health Policy Board gets created. We have new methodologies for delivering care, the coordinated care model, which we've been at work on, integration of behavioral health, telemedicine becoming something new. I think people understand that more care can be delivered through technology, remotely, and that's change. We're continuing to engage in payment reform, and at the same time, where are we now? There's a lot of uncertainty at the federal level with policy. GME funding, graduate medical education funding, which has held Oregon back in many ways from being able to grow more of our own. The rules haven't changed, but there may be some breaking of the ice there. Questionable funding for programs like the National Health Service Corps, which Oregon has relied on, teaching health centers, community health centers. What is going to happen? And one thing that has happened in Oregon between 2011 and 2019 is there's been more state money made available for better coordination of provider incentives. So how does that actually play out on the ground? Well, a couple of maps to show you. Many of you are familiar with the red map. This is a map of the 130 rural and non-rural service delivery areas. When we started the Healthcare Provider Incentive Program late 2017, we had an area of unmet need map developed by the State Office of Rural Health that looked like that. The colors don't show up very well on the wall, at least. They may show up better on the monitor, hopefully, for the audience. But you can see large areas like North Lake County. You can see Cape Junction, East Klamath. You see Glide. Those red areas mean the highest degree of need, generally lowest provider to population ratio. Employing resources, including the Healthcare Provider Incentive Program, beginning in 2018, that map has changed. And when we took another look in 2018, you see that big red splotch that used to be North Lake County, that's disappeared as a red map. East Klamath, unfortunately, is still red. But I think it was 8 of the areas that were among the worst 16 areas are no longer at the bottom, due in part to the efforts to target resources to help recruit and retain healthcare providers in primary care. So that's a little bit about where we are. What's the trending workforce picture? We do know that between 2010 and 2016, most health professions experienced some increase in the number of professionals practicing in Oregon, and there's some percentages on the board. Dentists plus 0.02%. That's not much of an increase. Physicians, though, a 3.9% increase. That's keeping pace and getting a little bit better against the growth in the state. A couple of other things to point out of what we've been able to do in the last 10 years. The How To Grant Program, which is actually run as a wonderful collaboration under the auspices of the board, really in collaboration between Kurt's office and our office, funded between OHA and Oregon Health Science University using intergovernmental transfer funds when the legislature did not see fit to make a general fund allocation in the 2017 session. The purposes of the How To Grant Program are up on the board. This board did receive a brief update from Dr. David Robinson, the Executive Vice Provost, shortly after the program started last year. So far, 10 projects have been funded. Round one, the winners were Virginia Garcia, the Community Health Worker Association, George Fox University, and Northeast Oregon AHEC. And round two, we have Samaritan, the Clackamas Workforce Partnership, which is the Workforce Investment Board, the Oregon-Washington Health Network, Northwest Portland Area India Health Board, Umpqua Community Health Center, and the Nextdoor Inc. These projects are a combination of primary care and behavioral health expansion efforts. 3 of them are going to expand the number of residencies and residency slots in Oregon for primary care and integrated care. And also a couple of them are expanding the number of community health workers. The Nextdoor Inc. is engaged in a project to expand access to culturally competent behavioral health services for the Hispanic community in the Gorge area. And finally, we're able to expand the number of trained medical assistants being trained in Northeast Oregon. But as Dr. Clark said, the main focus for today's presentation is not to tell you what has been, but to look at going forward. And the main focus is the board review and hopefully approval of the committee's preliminary recommendations for the use of the fund. And the basis for us coming today is the board's statutory responsibility under ORS 676467, that it's the board that shall determine the best allocation of monies in the Healthcare Provider Incentive Fund. And with that, I'm going to turn it over to my colleague, Joe Sullivan.
Thank you, Mark, and thank you guys for having us today. I appreciate your guys' time. As a Healthcare Provider Incentive Coordinator, I oversee this program and want to bring forth some of the proposals that we got from the healthcare workforce for recommendations of the usage of the funds in the Healthcare Provider Incentive Fund. During the time that we visited in the last year, I'm sure that you guys have seen this bucket chart that shows the original bucketing of the Healthcare Provider Incentive Fund, which includes $4 million for the rural insurance subsidy, $4 million for loan repayment, $1 million for loan forgiveness, as well as $5 million for SHOE and $1 million for other scholarships and SHOE-like at other institutions. The next slide is a bucket chart that we made that would represent the proposals that we'll bring in forth today and how we would like to see the bucketing done for the 2019 to 2021 biennium, which includes either keeping funding levels the same or increased funding levels in each of these bucketed areas. So to summarize the overall recommendations that I'll be talking to you guys about today, for loan repayment, we will be requesting that we add $1 million for a total of $5 million. For loan forgiveness, we're asking to add $500,000 for a total of $1.5 million in that bucket. For SHOE, we'd like to keep the 2020 amount at $2.5 million and have further discussion with OHSU about the logistics and effectiveness of the program under discussion. For SHOE-like, we'd like to maintain the same funding level and allow those programs to mature and possibly engage some other programs throughout the state. For the rural insurance subsidy, we'd like to recommend no change there and keep the funding level at $4 million. But we'd also like to have a possible discussion around administrative rule review of provider eligibility criteria for the rural insurance subsidy. And for the administrative bucket, we would like no change and to leave that at the $1 million cap. Our other point of business would be to come back to you guys in the spring of 2020 with further recommendations for the remaining funds, as the proposals that we're bringing forward today will leave about $4.2 million on the table. So Now, getting into the background of what we've done with the money that you guys allotted us during the previous biennium. For loan repayment in 2017 to 2019, we were able to give out 83 awards in loan repayment. The total cost of those awards was about $3.8 million, which equates to an average of about $46,000 per awardee. So that's indicative of us being able to contract with providers for a much lesser amount than the maximum award possibility of $105,000 for this program. 33 of those awardees identified as being able to fluently speak a language other than English. Of the awardees, 15 identified as being non-white, non-Hispanic. And these awards are being targeted towards areas with high needs, but not meeting the threshold necessary for NHSC funding. So the National Health Service Score in most cases requires a health professional shortage area score or a HPSA score to be at least 17 for loan repayment to be received by its applicants. Because of the investments that Oregon has made into its healthcare workforce, some of the funds unfortunately do not reach our providers. In order to maximize resources, the Healthcare Provider Incentive Program continues to prioritize resources to those in HPSA score areas below 17, but still with high needs. So with Oregon's needs still being high, but HPSA scores dropping due to the investments we're making, we'll likely have access to fewer federal dollars, and the program will be able to fill fewer gaps. For each of those reasons, we're asking for an additional $1 million for the Healthcare Provider Incentive Program's loan repayment to incentivize the providers that would have previously had access to those NHSC dollars but are unable to receive them now. In regards to the loan forgiveness incentive, we were able to award 24 future healthcare professionals during the 2017-2019 biennium. This utilized all but about $25,000 of the $1 million bucketed for primary care loan forgiveness, and that leftover was just a result of the cost of schooling it, not just equaling $1 million. But we definitely gave out the full amount of awards that we were able to during that biennium. I'll let Kurt speak a little bit to an uptick in the AHEC rural tracks and how that might have impact on the interest and the amount of applications that we get for loan forgiveness and why we'd appreciate an extra $500,000 for this incentive.
Thank you, Joe. One of the prerequisites of this incentive program is that students participate in a rural track in their health care training. And prior to 2017, there were only 4 programs that had a designated rural track. So only 4 sets of students were eligible to apply for this, and that included OHSU School of Medicine, Osteopathic School of Medicine in Lebanon, and the 2 PA programs at Pacific and then at OHSU. In 2017, with the launch of the AHEC Scholars Program, which is a rural track program for students, we were able to expand the number of students by leaps and bounds. So we expanded to 4 different institutions and 9 different schools and programs, which meant for the first time pharmacists, dentists, nurse practitioners, and undergraduate nurses were eligible to apply for these funds. And so that's why we're seeing an uptick in interest, an uptick in numbers of applicants, and we anticipate that to continue in the future as the AHEC Scholars Program or the new rural track program for the state continues to expand to include things like graduate psychology and social work.
Thank you, Kurt. So in order to support the further expansion of AHEC rural tracks and in turn contract with more scholars, the program is requesting the additional $500,000 to be used for this incentive. In regards to the Scholars for Healthy Oregon initiative, it's a program housed at OHSU to support their students with scholarships equal to the cost of tuition and fees. We propose keeping the funding level the same for 2020 by utilizing the $2.5 million for this incentive and exploring program parameters and funding for 2021 with OHSU. And just to clarify, that is not a funding level change in terms of the SHOE program. Essentially, we just give the 2.5 in 2 different payments on a year-to-year basis, just trying to increase the level of administrative involvement and support from OHA. So Show We Like is a new incentive that we started with the Healthcare Provider Incentive Program in early 2018. It's a scholarship program similar to Scholars for Healthy Oregon for students who are at institutions other than OHSU. For the previous biennium, we had $1 million budget and utilized about $750,000 for programs at Comp Northwest, NUNM, and Pacific University. Being that these programs were in their first iterations during the last biennium, it is our intention to let the programs mature and continue at their same funding level. There is potential of adding additional schools, which we will explore, and we would still be able to do at the same funding level as there were some funds unspent during the previous biennium. So for this biennium, we propose keeping Show We Like funded at $1 million.
So this particular topic, we spent a bit of time on in our last committee meeting. And going back to the charter for managing these incentive funds, the word best in our interpretation includes reevaluating where we're spending money and to say, are we really gaining anything from the spending of those dollars? There's one topic that will be in the details here about the lowest tier of rural insurance subsidy. Amounts to about $500 per provider, but in total is about $1 million. And so we really question whether or not that is an effective use of that money because of the dilution. $500 is probably not going to be the thing that tips a person over on where they're going to live and work. $1 million used in some of these other programs, however, could be used in a way that is meaningful to modify where a person might go to live and practice. So I just would like to ask, is that correct? We should be also looking at places where we're spending money and saying, well, maybe that isn't the best use.
So when you say lowest category, I'm not sure I understand what you mean by that.
There are 4 tiers.
Yeah, so there is 4 tiers of the rural insurance subsidy. So the malpractice premiums are paid based on the type of provider that someone is. So an 80% group exists that's for OB, GYNs working in rural Oregon. A 60% group exists for doctors that have gynecology as part of their specialty. 40% group, which is family practice clinicians, and then a 15% group, which was actually written in the rule just kind of like any other provider other than those listed at A through C above.
So I thought it was primary care, not just family practice?
Family practice, what used to be called general practice,
Yeah.
internal medicine. I would say you're right, Carl, about
Okay.
that. Yeah.
All right.
If you go to the next slide, I think that would
So
also
let
be
me
helpful.
just finish
Sure.
up, and then I'll let you guys get on with the presentation. So we had a proposal brought forward at the Healthcare Workforce Committee to say, let's not spend that 15% that way. Let's concentrate that back up into another $1 million in the unallocated bucket. We are not bringing that proposal today because there was discussion about process. The people who are currently enjoying that subsidy need to have notification. We need to go through rules, which was alluded to actually change that. This is something we would still like to do, but the more fundamental question is this something, the kind of thing that we should be looking at also, in addition to where to spend money, but where we might want to reallocate. And I think we're kind of hoping to get a guidance from you guys on that.
Is this the group that most of the nurse practitioners are in?
No.
No, there's
So are
only
they in one of these other 3 categories?
yeah. So there's
then?
only 18 nurse practitioners in that group at this time.
So are they covered in the primary care? So does primary care include physicians and nurse practitioners?
Yes, all 3 categories include both MDs and DOs and nurse practitioners.
Okay, what about nurse midwives?
So right now it's just MDs, DOs, and NPs.
I'm sorry, I'm confused.
Mhm.
So this only applies to the 15% subsidy group? Doesn't apply to the 80, the 60?
Correct.
The 40?
Mhm.
Which, didn't the 40 have some of the primary care doctors in it?
Right, that's what I was asking.
Yeah.
So I think OBs are top, and then you said with gynecology, but I thought it was like family practice with OB.
There'll be specialty
Yeah.
or gynecology,
And
that's
then-
right.
And then primary care.
So the amount of money is much smaller than $1 million that this would free up.
It frees up about $800,000 because the 500 is an average, and there are people in that group that have malpractice premiums far greater than $500.
If you could go back to the previous slide.
Okay.
You can see we might have done well to include all 4 categories and broken it down, but on the whole, there were about 520 physicians and nurse practitioners, mostly physicians, who took advantage of the subsidy. And as you know, the subsidy has been around for many, many years, and at the time it was really believed that without paying some good portion of the medical malpractice insurance for, in particular, OB, it's like, no, we can't get OBs to work in rural
Right.
Oregon, so
I
that
remember that.
made sense. Now, things are also different. There are way more folks who are not independently employed any longer. There are providers who have their insurance paid by their employers. What we looked at only, the committee looked only at the lowest tier, did not suggest that the 80%, the 60%, or the 40% should have any changes at all. But with regard to Joe, if you could move over to the next slide, the 168 folks out of the 521, the question was, is spending $800,000+ on that particular subsidy the best use of state resources?
But the question I thought I heard framed up was actually a little bit for the board today. It was a little different than that, right?
Yeah.
What I think I heard framed up was, does the board want the committee generically considering existing programs and whether they continue to be effective in proposing changes, not whether the board today supports any kind of proposed change
That's
around
right.
this? Did I get that right?
This is the example.
Okay.
This is the example that brings a larger question to give guidance going forward.
I think just absolutely would be my answer to the question. I think it's stewardship. I think the tone and tenor of the conversations the committee have had have been very thoughtful and deliberate around most effective use. And I think the other piece of it is then how do we actually answer that question? How do we identify by feedback from those that would be impacted around whether or not it actually matters? And so the question, I think, for the committee is more about your evaluation process more than, these one-off kind of decision points. So, yeah, thank you.
Well, in all cases, they would result in a recommendation to this group, and among the many questions, did we do our due diligence, right? So,
Can we just ask questions?
Yeah.
Are you all?
Yeah, I think this is a great
I
job.
think this is really terrific, and a really terrific report. I know I would be just interested in how many of the folks in any of these programs are active in a CCO. I'd be interested in, some of them are, I think, tribal. You mentioned the involvement of some of the tribal folks. I mean, we've certainly been in areas where there are tribes who say, it's tough for us to recruit people. And so I assume the tribes are all eligible.
That is correct.
For this. How many are in PCPCH, and CPC Plus? I'm not saying that they should be required to, I'm just interested. Because ultimately, again, sorry to get to our next discussion, this is repairing an inequity. This is repairing something that was unfair and unjust. To the degree that it can be measured, that it's repairing something that's unfair or unjust is a really good thing.
Thank you very much for your feedback. I'll continue to expand the type of information that we're gathering. I have done some looking into the activity and whether or not someone's on a Medicaid panel, and I can continue to gather data around how many people are in tribal health centers and PCPCHs, CPC Plus. I'll gather that data.
I also was impressed, that last slide shows that people are shifting to organizations to be employed. Those subsidies are really focused on folks in private practice, it sounds like, which, I think that business form should be stabilized through this period of transition. While it may be getting less, and maybe there's good reasons for that, it was and is an important piece of the delivery system, and it's appropriate to keep it as stable as possible, because some of these communities wouldn't take much in terms of people saying goodbye to become destabilized.
With that said, I also wonder though if we should be looking at the fact that the landscape for healthcare has really changed so that you have more healthcare providers that are employed and not independent. And I think that's probably specifically true at a higher rate for nurse practitioners and PAs. So by setting these restrictions for independent practice, are we discouraging healthcare systems to hire people within those categories because of malpractice rates? I think one group that's in that lower category might be surgeons. And, you know, I've seen rural communities devastated because they lost their general surgeon.
They are in the 40% group, general
okay.
surgery,
All right.
but yeah.
And so if you have a general surgeon that's employed by a healthcare system, but they don't get the subsidy, does that somehow disincentivize the healthcare system for putting a general surgeon out in a rural area? So with that shift, it's been, I think, a significant shift in the past 10 years, 15 years. You know, should we be re-looking at that requirement so that we encourage clinic systems and healthcare systems who have facilities in rural areas so that they are looking at putting these higher risk, so to speak, providers out there, so.
And so one use of that 15%, if we brought it back to a concentrated form, one other place to do it would be to put more money into those higher tiers. I mean, I don't know, we have a specific proposal for that, but with that and loan forgiveness and other subsidies to get people of those skills to be in the places we need them, it's more meaningful than you know, an average of $500. I think that was our biggest thing, is like, does this really make any difference in a final decision? And I think we don't feel it does. But the proposal's not here yet because we're wanting to make sure we're okay to go make those proposals.
Yeah, as we stand, we definitely want to keep the funding level at the same and be able to go back and do the research to really connect those dots and have the quantitative data to drive the decision making and really making sure that that 15% group isn't in fact working where they're working and having their behavior incentivized, namely where they work, by that what we consider, you know, more of a nominal amount of money compared to the other categories. But in and of itself, it's still an incentive for people who are working in these rural areas that I imagine we'll hear is important to them. As I've driven around the state and met with tens of clinics, I've rarely heard anyone tell me that they don't need the funds,
Yeah.
or that they're not actually critical.
Or that
towards
they would like you to
people's
take money away from them
Yes.
that they've been enjoying now.
Yeah.
So
How long will it take you to complete the analysis for the 15%? Like when would we anticipate revisiting this conversation?
Well,
So
2020, right?
doing the actual analysis of the data could happen pretty quickly. I think that if there was a decision to actually move forward with consideration of convening a rule advisory committee, that then it becomes a 45-day timeline, which is written into the rules in terms of how long we have to give notification to the providers of any change in rule. So I think just making sure that we're mindful of the communication that we'd have to those who would be affected by any change, and building that into the timeline. So probably a few months out.
And we are planning and hope to come back in early 2020 back to the board to speak about whatever's not allocated today. And right now, again, even though we're talking about the 15% in the rural insurance subsidy, the committee's recommendation is not to do anything with that $4 million level. So we would come back in the spring, talk about $4.2 million, or maybe more if the committee had the analysis and the board was interested in, here's the evaluation of what's happening with that $800,000.
I assume one of the things you could also consider, although it doesn't free up the $1 million immediately, is you just stop enrolling new providers in a particular program and just kind of wind it down, right?
You could.
Yeah, and
But we still need a rule change for that. So.
Well, and if we did that, the process wouldn't be able to happen until the end of 2020 because the affidavits are being posted right now and the eligibility begins on 1/1 of each calendar year. So essentially, yeah, we would have kind of the 2020 calendar year to explore things, and then eligibility wouldn't actually be affected until 2021 because those who are deemed eligible during this next 2-month period, I'm not just proposing to pull that subsidy from in the middle of the year.
And is there kind of longevity to who's has been using this subsidy, or is there?
We do have a way of determining that.
Yeah, I don't have the exact numbers in my head.
So, correct me if I'm wrong, there's a letter in the packet, and what you're asking for is approval related to what's outlined in the letter, is that correct?
That's right.
So I just have one more question. I noticed under primary care loan forgiveness, under additional schools programs added in the past 15 months, you have OHSU School of Nursing program in LeGrand. So is the main OHSU program not, School of Nursing not included in this?
Just the Family Nurse Practitioner Program at
Okay.
OHSU Maine, and then the School of Nursing in LeGrand is part of a local HRSA grant that they got just for the School of Nursing in LeGrand for primary care nursing in rural clinics, program that they're running, which we combined with our AHEC Scholars, which is why there's 6 students in that program, which is why it's just in LeGrand, because they were the only ones who got the HRSA grant for the primary care.
The reason why I'm asking is because I know community colleges, they have their associate's degree of nursing, and then those students in some of the community colleges, I don't know if it's all, then are able to attend online school with OHSU. So they're able to stay in their rural community and do their education there and their clinicals there. But I think that's through the main OHSU School of Nursing.
Correct.
But they would not be eligible for primary care loan forgiveness then, is that right?
If they were to enroll in a AHEC Scholars Program or develop their own rural track at their local campus or within the school, undergraduate school of nursing, then they would be. So the prerequisite to get access to the primary care loan forgiveness fund is that you participate in a rural track. In our case, it's AHEC Scholars. That's the rural track that most universities, I should say all universities, are using as the rural track. If the School of Nursing in Ashland or Monmouth or even Portland wanted their students to become eligible for primary care loan forgiveness, they would either need to enroll in AHEC Scholars, which they can certainly do, or they would need to develop their own rural track at their campus or within their school, which again, they could certainly do. At that point, once that is certified might not be the right, but once that's deemed, okay, that's an official rural track by the Office of Rural Health, then they're eligible to apply.
And so have any of the community colleges done that?
No.
Like at SWAC or Umpqua or?
Not to my knowledge.
Okay,
No.
do we know why? Because it seems like that would be very,
Yeah.
like I know nursing, associate's degree nurses who have gone on to get their BSN, but they haven't done it through OHSU because of the tuition, and so they are attending other online schools related to that, but they're staying in their communities, and it seems like that's the group of students we want to encourage.
Yeah, my guess is, Carla, is that they're probably not even aware that primary care loan
Uh-huh.
forgiveness exists and that their school or institution or program would need to do some changes or, make a rural
Uh-huh.
track or adopt the AHEC Scholars rural track, and then they would thus be eligible. So it's probably just a situation of we need to communicate and educate those individuals at those community colleges that, hey, you can participate in AHEC Scholars or develop your own rural track and you would thus be eligible for primary care loan forgiveness.
Okay, thank you.
Carla, quick comment. One of the things that I stood out for me when I started reading your materials was the charter and the committee code. It felt like a very type of a vanilla approach to the healthcare workforce. And I understand that this was done nearly 10 years ago, and we're in a much different place than we are now, 10 years later. But I wonder if there's been conversations about really looking at that again and talking more about what would it look like to also, include the health equity conversations that are happening in social determinants of health and the health equity definition that the Health Equity Committee is developing, and sort of really push this to the next level of not just recruiting and retaining healthcare work professionals, but really diversifying the healthcare workforce so that it reflects the population that is in Oregon. And also, same thing with the charter. I didn't really see anything there about efforts to kind of diversify the workforce. So I wonder if you guys have had conversations about, looking at this code, and I know how hard it is, how hard it could be to change code, but just thoughts around that.
A couple of things, Oscar. Thank you for that. One offer is that while changing statute may not be the way to go, this board does re-charter the workforce committee every 2 years, so it would be in the spring, and we can certainly speak with our new liaison about what else or what different the board would like to see compared with the existing charter, which is about a 4-page document. I think we've been proud of some of the discussions that have taken place specifically around diversification of the workforce, but if the charter is not reflective of the board's real priorities and values, we ought to get it that way.
I think it's a great question. I'm happy to be engaged with that conversation as we move forward, and I'd also extend that comment to the rest of our board committees. I think that's part of what we'll probably hear from our Health Equity Committee as well, is the importance of finding alignment, both at the board level here for ourselves and then in each of the committees of the board. So look forward to that.
And I'll just respond by saying, certainly it's at the one level of the charter and the code for the Healthcare Workforce Committee. Programs like we've been discussing today, like specifically the SHOE program, is really designed and targeted towards individuals from diverse backgrounds, individuals from underrepresented minority backgrounds, individuals from economically and educationally disadvantaged backgrounds. So there are some programs that do help increase the diversity in all of its forms of the healthcare workforce, just by nature of some of the programs that we've been talking about here. But I agree, it needs to funnel up to reflect this kind of language.
No, I appreciate the intentionality around the programs and the strategies, but I also think if you don't start from it at the very beginning, what's written in code or what's at the charter level, it's going to be really hard to kind of be able to go back to that as a cornerstone.
Yeah, the healthcare provider incentive program, we've definitely been very focused on making sure that healthcare workforce is reflective of the populations that it's serving, and I'm trying to kind of have that equity lens on the awards that we're making, as well as the different sites that are able to participate. But I definitely agree it is something that we kind of need to roll up to that higher level and not just have it be reflective of in programmatic operations, but of the charter and the code as well. Thank you.
I could understand why there's a lot of focus on kind of higher level providers, or at least from my perspective, working with a lot of service workers. But I was curious if you ever get into workforce that's not at the provider level. So like, how do we incentivize, well, you talked about an MA program actually, or CNAs, in the same vein of like, there's a lot of people who touch patients along the way. How are they all being recruited and most capable of being culturally competent here?
Yeah. I think that the how-to program is probably most indicative, or the best place where those opportunities have come up. The way that the healthcare provider incentive program, the rules and statutes were written around it, it's focused on post-baccalaureate loan repayment. So the opportunity to support clinicians or providers who aren't receiving an education to that level is unfortunately not available at this time. But how-to definitely fills a lot of that gap.
But I would also say the primary care loan forgiveness program, as it expands, will include not just physicians, PAs, and nurse practitioners. As I mentioned, it's also including, granted, their graduate degrees, dentists, pharmacists, nurse practitioners, and behavioral mental health. So as the AHEC Scholars Program expands to include more schools and programs, we might see it expanding into some of the non-provider, non-licensed, professional type of that we might all think of on the healthcare team.
And we have begun to do that on the loan repayment program in the behavioral health arena. So not just licensed clinical social workers, but for example, those behavioral health professionals who are committed to being licensed in the future, but are still engaged in getting their clinical practice hours to have that license are eligible now.
Correct.
Yeah, my recollection, remember in Lakeview, was I don't think they had a licensed clinical social worker. I think that all of their mental health workers were bachelor or other, and they had made a difference. And that's who they could recruit.
I think particularly around behavioral health, finding an opportunity to incentivize QMHPs regardless of how it may look, whether or not that's for licensure or just to incentivize them for the work that they're doing. Particularly when I speak to SPHCs and some of these other clinic models that are heavily relying on QMHPs to render their mental health services, that's something that we can kind of continue to explore how we can support as we look at utilization of some of the other dollars that we have left over as well.
I think it's a really great leading question to the committee to continue to explore, and to whatever degree we have discretion in the remaining balance or funds that you'll be bringing back to us in the spring, that we also analyze wage progression for low earners, wage earners in the healthcare space. We've been informed in the past about where shortages and areas are that aren't just at the provider level, so I think that's helpful kind of context for us to re-emerge. And to think about alignment with the traditional health worker, kind of movement and evolution, and where we can think more innovatively around that discretionary resource, or to what extent we have discretion around the use of funds. It's exciting.
Madam Chair, before you move to a vote, just a couple of points of personal privilege. I realize that the board met last month in Coos County, so it's really nice for us to be able to come and talk a little bit about the details of some of the programs you heard maybe very generically about, like, oh, we've been really helped by the J1 program. We didn't talk about the J1 program, but no, loan repayment or state program, here it is. So kind of the impact, and then here are the details, and here's more of what we want from you. And then just lastly, personal privilege. It's really been wonderful to have Dr. McKelvey as the liaison to the committee for so many years, and we will miss you.
I will miss you too. Thank you. So we have before us recommendations from the Healthcare Workforce Committee. And so for your, hopefully, approval. So any further discussion? Not, do I have a motion?
So moved.
Second.
All in favor?
Aye.
Opposed? Great. And then you said the new charter will come up in the spring?
Mhm.
Okay, all right. And so there'll be an opportunity to make sure we have the language in there. So thank you very much, and thank you for the work you do.
Thank you guys. Appreciate your time.
All right, so we are moving along here. So we have Health Equity Committee. Carly, I think you said on the phone. Is that what you said, Jeff? Yes, okay. So Carly's on the phone, and we have Michael and Leanne. Welcome.
Thank you. Good morning. We are pleased to bring to you some information about work that we've been doing on the health equity definition, and we have a proposal to bring forward. First of all, for the record, my name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority. I'll turn it over to Michael for introduction.
And my name is Michael Anderson-Nathy. I'm one of the Health Equity Committee co-chairs. I also serve as the Chief Equity and Engagement Officer for Health Share of Oregon through the end of this month. And then I will be up on my own. And then Carly is also on the phone. I don't know, Carly, if you can introduce yourself real quick. Oh, and I use him, his pronouns.
She, her, hers.
She might be on mute.
Carly?
Carly, are
Good morning. Yes, I'm here. Good morning, everyone. Apologies I can't be in person. I'm tied up in an all-day meeting, but wanted to be here present for the sharing of this definition. I am currently one of the co-chairs and also work at the Oregon Primary Care Association. My preferred pronouns are she, her, hers.
All right, so I will begin by setting, I'm going to set some introductory context for the definition, how we got there, why we are charged to do that, and just to set the stage for the conversation that I'm sure will be very robust around this. So as you all know, the Health Equity Committee, the role is to make recommendations to the Oregon Health Policy Board as well as the Oregon Health Authority and the broader health system in Oregon regarding health equity and the utilization of a health equity lens. Moving clockwise on this slide, so it was the charge of the Health Equity Committee to develop an equity framework as part of that initial direction and charge for the Oregon Health Policy Board. And it was critical that if we are moving into a health equity framework, that we need to have a common definition around health equity. So currently, having no definition that is utilized across the system, that can really pose barriers to effective engagement, action around health equity work, and also I think lack of clarity around dynamics and concepts in terms of what the work is intended to be and to do. So this is our work is to bring it into focus as to what we mean when we say health equity and working toward health equity, utilizing the health equity framework. So having that consensus is going to be really critical to foster forward movement and to bridge gaps in understanding and bridge any divides that may exist around that. So that's the need. So one of the areas when we talk about concepts and dynamics, one of the areas that has needed some clarity is really around conversations. And a little bit it's about semantics, but it's also about dynamics and context as well. And that is the conversation of health disparities and the conversation of health inequities. So many health disparities exist, as we are aware, and in the state of Oregon and in this nation. And that focus or that definition really speaks to the inequalities in health inequalities in the system. And those are differences in health outcomes, presence of disease, and access to health care between various population groups. So those are the numbers we see on the page, the health disparities. What we want to drill down to in our work are health inequities that are rooted in social injustices and that make certain populations of people in our state more vulnerable to poor health outcomes. And so our definition really focuses in on those specific populations that have decades, if not centuries, of social injustices that they have endured and that have indeed impacted their opportunity for optimal health. So these inequities that we're talking about are both avoidable and unnecessary, and of course unfair and unjust. So that's the focus we're taking. There are many health disparities that exist, and where we focus down are on health disparities that are created by health inequities, social inequities, and that injustice. So those are the types of disparities that we're talking about. So the way we kind of think about it is this: social inequities lead to health inequities, and then those are represented in health disparities in very specific populations of people, including people of color, immigrant and refugee populations, LGBTQ populations, people with disabilities. So those are some of our more, the populations an example of the populations that we are prioritizing. So I wanted just to give an example that will help hopefully illuminate this. So when we talk about a disparity, one example would be the unfortunate fact that male babies are born at a heavier weight than female babies. This is a disparity. And there's many of those that exist. So that's what when we say health disparities, we're talking about those general terms and general health outcomes. But when we talk about inequities, we go to very specific populations. So for example, babies that are born to Black women are more likely to die in their first year of life than babies born to white women. And I think while there are higher percentages of Black women that do face poverty and hardship, what we're talking about here is the fact that there's certain risk factors and certain protective factors. And when we talk about these inequities, we're talking about the fact that protective factors such as wealth and education do not factor in. So another disparity that exists related to childbirth is that when we look at that first bullet, for example, about babies born to black women, that education doesn't matter. So a baby born to a black woman who's educated through college is still more likely to die in that first year than a baby born to a white woman who did not complete high school. So we're talking about inequities and the link between stress and racism and discrimination and the health inequities that exist because of social injustice that has once again occurred from decades to centuries in our country. Okay, so the next one. And then this is the last slide I'm going to. It's just kind of knocks it out of the park and further illuminates the structure that we're looking at and the fact that we see that furthest upstream in the health equity conversation, while we often think of social determinants of health as upstream, it's about midstream. And further upstream are discriminatory beliefs that have created oppressive actions, that have created inequities, social inequities in systems, that have created policies and practice that create barriers at various ways for the populations of people that we are focusing on with our definition today. And there's also been a recent report that was done, and I've got it right here. It's the 2019 Community Health Needs Assessment, and it was a 4-county area, including Multnomah County, the metropolitan area, as well as Southwest Washington. And this report says that trauma, discrimination, and harassment, discrimination, racism, actually are the greatest drivers for health inequities and disparities in health outcomes related to those social inequities. So we're really trying to take this back as far as we can in our work. And it doesn't mean that we're not focused on those numbers on the page and the disparities, but what we're looking at right now is if we're talking about a measurement, for example, how are we measuring the presence of health equity in a health delivery system? And so this definition is a reflection of that work and of the social inequities that lead to the health inequities that lead to those health disparities. I'll stop there and turn it over to Michael.
Well, I think, oops.
Oh, I didn't know that.
Yeah. So I think this is
so much for technology.
Carly. I think Carly's up next.
Okay.
And Carly, we are moving on to the feedback overview section, and so I can advance a slide for you. So now we're on the table for source of feedback and content themes if you want to take it. And then just tell me when you want me to advance.
Perfect. Great. Yes. So you have the table up in front of you, Michael?
Yep.
Okay, perfect. So before we share kind of the final definition that we've settled on, I wanted to walk through our process for arriving to that definition that we've settled on as a committee, as there was quite a bit of work that went into that. We wanted to distill exactly what that process was. So we started back in May by combing through, well, actually probably before that, we started combing through a lot of the literature, looking at how organizations like the CDC and the World Health Organization really define health equity based on the work of many people who've come before us. We also looked really locally at how other committees such as the FAB and the Medicaid Advisory Committee have defined both social determinants of health and health equity to ensure that we weren't reinventing the wheel or not taking into consideration the work of folks who started this before the committee had an opportunity to. From these, we worked to draft an initial definition and then identify opportunities as a committee to really engage community in providing feedback and community wisdom on how we were defining health equity at that point in time, things that folks wanted to raise as concerns or questions that they had about the existing definition at that point. And you'll recall that we had brought the definition at that point in time back to you all in May during the Health Equity Committee's presentation to OHPB. So on the screen, you can see a number of those sources of feedback that were collected between May and July of this year. Your feedback was taken into account, of course, there as well. And for each conversation, a focus group, email, or other sort of mechanism that we had to receive that feedback, OHA staff documented the content of that feedback and the rationale that was provided. You can see some on the screen there, and while not all encompassing, we couldn't list the plethora of feedback opportunities that we received. You can see the wide array of opinions and perspectives that we received and really tried to incorporate. For aspects that were not included, the rationale and justification for the committee's decision not to include or to slightly alter language has also been documented, and we're happy to provide that. Next slide. So we focused on a set of key assumptions and values to lift this definition up, and I think it's imperative that we kind of call those out specifically. The first, it feels fairly common to a lot of the definitions that we encountered, but really focusing on true wellness and not merely the absence of disease. When we think about equity, we want to think about that holistically to include spiritual, mental, physical, all kinds of health. And so we wanted to really call that out. The second is that we believe everyone has a right to a foundation of services, not just medical services, but those that also intersect with health outcomes, such as nutrition, education, housing, among others. And so we wanted to lift that up as well. The third value is to really call out the intersectionality of some of these identities and demographics. And this came up in a number of the feedback that we received. But specifically rurality and race ethnicity and the inequities that are really compounded when you take into consideration where a person lives and their race ethnicity. So we wanted to call out and be intentional about kind of the intersectionality of many of these factors in this definition. The fourth, on the bottom left there, is a focus on the systemic, social, and political implications that Leanne just mentioned are actually upstream of even the social determinants of health, but ultimately lead to the biggest discrepancies in health outcomes. So we wanted that to be transparent and very clear. And then the fifth is, to achieve health equity and better align with our intentions in that area, we really need to address some of those systemic issues that are unjust, unfair, and really unavoidable. And then the last assumption and value that we put into this definition before I turn it back over to Michael to share is just that equity must be really intentionally pursued as a strategy. And I think I'm reflecting on my time as a co-chair. We came at the May, I think it was 2017, the first meeting we had to present to OHPB as a committee. And I think that was something that we really hoped to share and communicate was the importance of being intentional with equity work. And so I think that is reflected also in this definition. So with that, I will turn it back over to Michael to actually share what we've come up with.
Thank you. So we're going to get to the health equity definition, and I guess I'm going to go a little off script here and say I think one of the things that I would say our committee wants folks to understand is that this is not the end-all be-all definition. It's not going to meet everybody's needs or purposes. And what I mean by that is that as we were working with folks and getting feedback, one of the things we started to hear and understand with the questions is that everyone kind of was looking for this one single definition to help them evaluate or help them implement a program or help them assess a policy. And I mean, there's a lot of different ways in which we might push health equity forward, and a single definition is not going to do all of that. What it is supposed to do is provide us with some guidance and a long-term vision to figure out how we put those things in place, how we operationalize this work to get to that. And so if you read this definition or you listen to it and you think specifically around how can I evaluate it, you might miss some of the other opportunities that it provides. So I just kind of wanted to put that as a framing. So here's the definition that our group landed on, and it did come from the full Health Equity Committee. They were unanimous in putting it forward. I will read it for folks who are on the phone who may not be able to see the slide. So it is, Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistributing of resources and power, and recognizing, reconciling, and rectifying historical contemporary injustices. So, I know that's kind of a mouthful. Give you a little more context that we wanted to provide with our definition. As you can see, and based on what Leon said earlier, you'll see that concepts of fairness and justice and looking at distributing of resources are big in our definition. Really, one of the ways that you move equity is really looking at how resources, including money and power and decision-making, are allocated. And so we wanted to call out that it actually takes looking at reallocating resources in some ways. We also wanted to really draw out that it's going to take collective action. So all sectors across the state are going to need to work together, and specifically that inaction is no longer acceptable, right? That we've talked a lot around health equity, health disparities, and how to move this, and have kind of gotten paralyzed with not moving forward. And so inaction is no longer acceptable. A couple things I just wanted to point out and lift up from our definition is recognition of the role of historical and contemporary injustices. I think oftentimes we like to talk about the past around health equity, and some of these injustices are still currently happening. And when we don't acknowledge that, it is another way that we continue to marginalize some of our communities and discount their experience and kind of hold them back. And so we need to be okay with recognizing where we continue to miss the mark in our communities and where we continue to perpetuate some of these injustices so that we can actually tackle them. So we make sure that contemporary is in there. We also wanted structural barriers to be put in place. I think oftentimes a lot of systems will talk about kind of, well, their organization or the people in their organization are not necessarily problems or barriers, but there are deeply rooted structural barriers that all of our systems are a part of perpetuating that need to be addressed in order to really move equity forward. And so you'll see that in there as well. Again, want a wide range of partners representing diverse constituencies to really help move this work forward, and direct involvement from those affected communities as partners in this work. And so not necessarily working for or on behalf, but working with communities with lived experiences and really letting their leadership be a part of solving the problem. And so when we think about and we look about who's around the tables where policies and decisions are being made, ask yourself, are folks from affected communities there at the table? Are they truly given some of that power? Are we redistributing resources and power to those folks to help make some of the changes that they want for their communities? All right. We wanted to offer some kind of concrete ideas for how OHPB and OHA might advance health equity. And so here are the ones that we kind of talked about as a committee. So breaking down current silos and considering health equity in every policy and business decision. So really looking across OHA and then figure out how health equity is impacting the way you all do business and the policies that you're putting forward. Adopting a shared vision for health equity is a starting point, right? And making sure kind of a next step, how does this health equity definition, if you adopt it, what's next for it? How do you then spread it across OHA? How do you then work with committees to make sure they have the capacity to figure out how to implement or operationalize some of this work, and how you would measure and evaluate it, how you would resource it? Aiming for greater alignment, amplification of existing efforts to advance health equity. And so really taking a look at where across OHA you are putting forward some effort and work, and where you're not, and really kind of figure out how you can align those. Building collective capacity and infrastructure at the organization committee level for change. I think that's again around making sure that you have the capacity internally to really advance and put this definition into action. And then creating and advancing systems changes and policies that result in reallocation of resources and power. And I guess this we want to, again, like it is about reallocating resources and power. It's not just around saying we're going to add this here or add this here. Sometimes you need to say the way we've done it in the past has not been working, and we need to change that. We need to actually shift those resources and power. So closing comments, I don't know if Carly or Leanne, I think we obviously want to hear questions from you all. Some of the things that we would want to hear from you all is what's next for this work, so the committee put forward this definition, but I think it's kind of up to OHPB for what's next in terms of whether or not you adopt it and how you then carry this forward into other parts of OHA and how you infuse it into the work of other committees and their divisions. And so would love to hear kind of your thoughts about that. And a kind of a clear example is I know we're still working on a health equity metric. And so thinking about, like in this case, how might a definition like this shape a metric? And just some thoughts about that. I don't know if Carly or Leanne have anything else they want to add or offer.
Carly, this is Leanne. Do you have anything else you'd like to add?
I don't. I think, I would love to hear thoughts and reflections from the board.
So one of the concerns that I've had is that this conversation has been going on in different committees. And I think that it's very important that there is a single definition for health equity versus each committee coming up with their own definition. And so that's why I think this work is so important, so that as they are looking at opportunities related to health equity and incorporating it in their conversations, that we're all on the same page and that we don't have 5 different committees with 5 different definitions. So my hope today is that as we look at this definition, if there is consensus, that we will be able to sign off on this, and then that this definition will be the definition that is utilized for the work. Specifically the committees that are reporting to the Oregon Health Policy Board. So that's my hope today.
It brings up a question for me, which I suppose might be for you, Pat, which is around the agency overall, and if it's your vision of a kind of idealized game plan, then it would be a common shared definition across, the Public Health Advisory Board, around all of the divisions within OHA.
Yeah, I think Dr. McKelvey is exactly right. Everyone running around with different definitions is not helpful to the work. I do think, though, we're at kind of a unique moment where landing on a consolidated definition is more helpful than it even would have been a year or two ago. I talked about the fact that we're engaging in strategic planning right now. We actually just had an agency leadership retreat yesterday where we spent a lot of time talking about health equity. It's a little bit cart before the horse, but certainly consistently using an equity lens as part of our decision-making process throughout the organization is something we're not currently doing that would be helpful, and this forms the basis of a really useful way to come at that issue. So I would be fully supportive of if the board adopts this definition of working to disseminate that throughout the agency and consistently use that as our equity definition.
Thank you.
May I add something, Dr. McKelvey? I would simply say that just as an example, because as Carly mentioned, there was quite a bit of engagement, and some of this language is very, very consistent with what the Public Health Advisory Board, is that correct?
Mm-hmm.
Is using. So it's not that far off. It's not off at all in terms of dynamics and concepts. Some of the words may be a little different, but I think that it's really going to be to align is not going to be a big heavy lift at this point in time.
I would also add, our committee is working on kind of ideally one-pager and maybe a recommendation that a visual also be made to kind of help take this definition and move it more into action. So providing some of that context and some suggestions and understandings that I think would be useful. That doesn't belong in a relatively short definition, but really needs to go hand in hand to figure out how we put it into action. And so that will also be a resource that we would offer up.
The work you've done on assumptions and values, I think, really does do some of that in helping extend the definition so that people can ground themselves in the concepts, I think, much differently than just the definition alone would provide. I just want to say I commend the committee on the level of engagement in the work itself. I know the heavy lift to arrive at this conclusion, at this moment in time. I just don't want to underestimate the amount of time, energy, and heartache that went into identifying the right words, each word being so carefully selected. So before we move, I just wanted to commend the work.
Thank you.
I do think one of the things the board will need to think about as it takes action is what's the verb that it wants to use with respect to the agency and your subcommittees in terms of how you want them to use this. Is it a ask them to integrate, recommend that they integrate, direct us to integrate, kind of a thing. And I think being clear about that will be helpful.
And therein lies one of our first tests, right? Around engagement, empowering, and thinking about inclusion in the context of arriving at a determination. You know, my preference would be not to mandate, but to strongly consider or create the framework by which people can arrive to the same conclusion that we may have arrived to. So whatever system that means in terms of engagement, you know, a less directive approach from my perspective would probably be one.
Yeah, I mean, I don't know that I have an opinion on where you land other than not really landing anywhere and everyone leaving thinking something different is probably not the best outcome.
Correct.
John?
I think this is really interesting and challenging, and you know, very meaningful definition, and I support it, but I think it's ambitious. It made me recall when I was appointed administrator of the Oregon Office of Healthcare Policy and Research, I was interviewed by Gene Derfler, who was the president of the Senate. And I can still remember him looking across the table at me and saying, your job is to try and convince us that resources and power should be reallocated from one group to another. And you better have your act together, because there's a lot of us who are going to insist that you convince us of that. And I was impressed with that, and he pursued that fairly, I think, but it was challenging. It is interesting to figure out, well, how do we measure this? You know, and it is interesting to think about measures that we have concluded that are successful, though a portion of people still aren't getting them. You know, for example, I'm still troubled that we eliminated colorectal screening, knowing that 60%, it was at 60%, and concluding that's the best we can do, even though we know there's a disparity about that. And you know, I think it will be interesting to look at the ones we've really succeeded at, but they'll all have a 5 or 10 or some rate that didn't get it. And you know, why didn't they get it? You know, these visits to, the third thing is these visits to the tribes have really been helpful to me. And this actually makes me wonder, you know, I always couldn't understand. So the tribes established sovereignty in the 80s, and they developed casinos. And you know, when we visited and I sat next to a board member, what he emphasized to me is that in the 1980s they had 770 acres of their 600,000 acre reservation. Now they have 200,000. Now that's a measurement. And it's because through sovereignty and casinos, they were able to reallocate resources and power. They were given power and they took it. And they reallocated resources. But that's a big deal, you know, to be able to do that. So, you know, and I think your comments about this is ongoing, I always, you know, sorry for a military analogy, but the general who said the best plan never survives the first shots. There's a lot more to come, and we need to keep track of it. So I think this is very interesting and insightful work.
Great. Thank you. I would agree that it's ambitious, and I think our committee really talked a lot about that. And I think what we came down to is like, look, here's an opportunity for some strong leadership from the state, right, from OHPV to say, hey, this is important to us, and it isn't ambitious, but if we're not willing to set an ambitious vision, then who is, right? And someone has to drive all of us towards what can be a reality for us, and who better than OHA? And I think that, you know, adopting a very ambitious definition and then resourcing a way to put it into action is how we're going to create that change. And so I think it is going to be challenging, but I know we can do it.
Oscar, do you have anything?
Yeah, no, I'm very excited about the framework and the definition. Great work from the committee. I really appreciate being at this point. I'm excited. I think I'm in total agreement with the language, and I'm very excited to support it. You know, I know we're going to talk about how we implement this later on, but I'm definitely more on the I think we should mandate it side. But I know that that's a conversation for the future. I would really hate for this great work to be put in the shelf and to sort of say, we did it, we're done, and to not look at it again. But I want to be able to like know how we're going to be intentionally looking at it regularly and using it and evaluating it. So,
Thank you.
I'll just speak because that was a fun poke at my mandate question. So, I just want to be clear. I think the intention in the solidarity around the definition is really unifying. And I think the question that I'm just pondering a little bit is that, you know, systems won't change until people have a felt experience of something else. And that when we, you know, say this is so, whatever the position of authority is, you know, that can be met with less successful results. So I know it's a tension that the team and the committee will be wrestling with for, I mean, we all will for quite some time, so.
Kirsten?
I just want to also echo the hard work that this represents, and also the kind of hope and vision that it represents for us as a state. And I feel like for Oregon to put the statement out here of like, this is what our health system, this is the definition of success in our health system is right, and it is the right spot. So I also really appreciate you mentioning the one pager that you guys are talking about developing, because I think people learn in different ways, and we need to be able to help all learners digest and apply this. And so I really like what you said about accompanying this with a one pager with a possible graphic version. Thank you. Thank you.
So with that conversation, what I'd like to suggest is we take a vote on the definition, and then I would like for us maybe, if we can, dive into what Pat's question is. What's the verb, I think you said? And so after the vote, I'd like to make a proposal around that. So do I have a motion to accept this definition?
So moved.
Second.
And it's that.
That, yes. All in favor?
Aye.
Opposed? Great. Long time coming, huh?
Yes,
All
thank
right.
you so much. And
So-
thank you for acknowledging the hard work. We appreciate that very much. Thank you. Thank you.
So my perspective on this is that I feel like we have given our committees a mandate to consider health equity. I think the gap that we have had is we haven't had a definition. And so I feel like we have a definition now. I would suggest that we use the verb inform, that definition informs that mandate requiring looking at health equity. So that's my thought, because I already feel like the mandate is there. I think we've said that we have that expectation. But now we actually have a definition to say, and here's the definition. So thoughts about that?
I think you're going to need to be clearer in circumstances where other entities have, in fact, in service of fulfilling that mandate, have adopted a definition. What do you want them to do with that definition?
I guess my initial response is they need to replace it.
I mean, I think
That's the point of this work.
I would actually love to hear from the Health Equity Committee, to actually hear from them what they think, you know, how this definition should be utilized before the board just kind of, you know, sort of makes a decision and decides in the next few minutes. But I think I'd love to kick it back to the committee if that's okay. Looking at Michael, and also would love to hear from Carly if that's like, you know, sort of us trying to avoid this conversation, or if that they would welcome the opportunity to weigh in and sort of bring that back to the board.
I just don't want to delay the continued work, because I think a lot of conversations have gone pretty far down the road. And so I think if the committee feels like they could address this and come back next month and say, here's our recommendations, that would be great. But I really don't want to delay it too long, just because I think it delays the importance of this.
May I ask for clarification? So, were you thinking, you wanted to hear from Michael and Carly today, or are you talking about a future meeting?
No, I mean, well, I want to hear about their thoughts of, yeah, does it make sense to take this back to the Health Equity Committee? And I also don't want to delay. I think we want to be able to move forward pretty quickly. But I would just love to hear thoughts from the Health Equity Committee about how this should be implemented, how this should be used.
I will respond off the top of my head here. So I think one of the things that we have taken away from our charter is that we are actually supposed to be working with all the other OHBB work committees around really infusing and addressing equity. And so I think this is our starting point or place with them. And we have currently been having each committee come to our monthly meetings to share the work that they're doing to look for those areas of collaboration and alignment. So I think immediate next step could be this committee sharing this definition with all of them and saying, this is the definition we have formally adopted. We are asking that you adopt it. If you have a current definition, to really look at what would it mean to your work to shift to this, and just encourage them to work with the Health Equity Committee to figure out how they are going to put it into action, and maybe think about giving them a deadline. And I think you could kick it back to the committee to say, what would we suggest are ways that would be evidence that they are in fact doing more than adopting it, but actually infusing it. And who knows, maybe we'll come up with some stuff like, a certain percentage of their work plan for the year has to address equity or moving forward, or maybe there has to be something that's aimed at a policy level that they're driving. I mean, I think that's stuff we could maybe try to help OHB, say here are some suggestions that every committee has to do to kind of put into action if you're looking for that. I don't know if we'll have that by next month.
Let me ask a clarifying question, just from the principles of inclusion, that the committees themselves were offered an opportunity to provide feedback around the definition creation in its formation, correct? That they all received a lot of communication and input and said now's the time and we're going to arrive at this conclusion, and so by this deadline provide feedback prior to today?
Yes.
I'm assuming that's correct. Yeah. Thank you.
So can you see a situation in which we wouldn't mandate this definition to be used by all these committees?
I don't. I mean, I don't see. I mean, I think that's the whole point of asking the committee to come up with a standard definition for OHA, for OHBB. So I think it makes sense to mandate that this is the one that they use, and that as a structure, we say the way that we're going to assess or evaluate your work is going to be based or informed on this. Is what I would do. But.
Jeff, did you?
I was just going to say, to the degree it's helpful, yeah, we've worked extensively with the committees of the board on this definition, and just like Michael's saying, I think that the thought was, the first avenue is to continue working with the committees of the board to spread the definition and see it implemented. I think the larger question that the board may be discussing, how the agency adopts and implements it, might be better to see, get some feedback from the committees, and exactly as you mentioned, Oscar, about what implementation on a committee level is looking like and how that might inform how the agency adopts and spreads it.
I feel like today we can make the decision to mandate the definition to be used by the committees that report to the policy board at a minimum. I think as far as the next steps, which is implementation and guidance, that is something that could be an ongoing conversation within the Health Equity Committee. But I think we have to have this starting place in order to have that other discussion. John?
Yeah, I agree. I mean, as onerous as some people think it is, you just can't get anywhere without some degree of standardization.
Yes.
And while it's, let 1,000 flowers bloom, and if you've seen one CCO, you've seen one. I mean, I think our direction has been to move towards standardization, and I just can't see how, you can have multiple definitions, and as difficult as it may be, you have to start somewhere. I do think in the world of measurement, I mean, as I read this, I realized, it's beyond disparities. And, that sequence that you showed, I think a lot of folks in the performance measurement world, their light bulbs will go off, that this is different, that just showing a disparity is present or can be improved. may not resolve the issue of whether there's equity. And the example is an excellent and challenging example. I agree that this should be standardized.
Can we do the mandate for the committees that report to this board and some sort of statement that is like an encouraging push to
Yeah.
the rest?
And Pat can jump in here. I feel like from a policy board's practicality that I feel like it's, for many reasons, to have the committees all working off the same definition is very important. I think obviously it would be good if the whole agency is. And so I'm looking to Pat about how much say we have over that. I think the implementation part of this with the committees as well as with the agency is something that should be an ongoing conversation, discussion, not only with the board, but with the Health Equity Committee.
Representative Greenwood would be quick to point out that you have absolute authority over the agency.
Speaking of
With-
power.
Regardless, this is a definition that I would want us to adopt in the agency, and I think uniformity across the health policy boards, subcommittees on that definition would help that.
Okay.
And may I add that, thank you, Pat, that some of this work also reflects the work of our Equity and Inclusion Division, and is very much in alignment with how Equity and Inclusion Division, the Health Authority, how we do our work, how we have been doing our work, how we build up the structure for our work. So, and being, one of the 20 members of the leadership team for the Oregon Health Authority, we have definite support from the Equity and Inclusion Division for this definition.
Okay, so with that said, do we need to take a vote about mandating the definition?
No.
Okay, so can we say that the policy board is a consensus that this definition should be mandated across the Oregon Health Authority, including the committees?
Can't we vote on it?
I
Okay,
think simply stating it is the definition.
we state that this is the definition for health equity that should be utilized across the Oregon Health Authority, including all the committees. Everybody?
Yes.
Okay.
In-
Let the minutes reflect everybody nodded. Yes.
Including the health policy boards subcommittees,
Yes.
to avoid confusion with the cluster of committees that we have that have sort of their own independent charge and charter and stuff that
Right.
could get weird fast, and we'll work on that.
Okay,
All right.
Jeff, John, you're not gonna.
I'm sure people will say, well, give us an example. And you do refer to the Boston Public Health Commission. And so I was able to go to their site, and there it is. And so this has been out there, and they do have some examples. And so I think any examples that you can find that you think are consistent, because I think the definition that they're using is the same or similar, would be helpful. And we're humans, and the first thing people will ask is, well, what's happened?
Yes. I think this does very much reflect both research, best practice, and wisdom of the communities. So I think at that intersection, while some people may want to argue with it, it's hard to argue with that type of a foundation.
And just to clarify, did we need, this is a pretty momentous occasion, I feel like, in terms of systems change. Did we need to make a motion and a second and actually vote?
Jeff says we do not,
You can, you're more than
but we
welcome.
can if you want to.
I think we should.
Okay, so, make sure I word this correctly.
I think you're looking for a motion that the board adopt this as the standard definition for health equity to be used by its subcommittees and by the agency.
Okay, there you go. So do I have a motion?
Is that an amendment to the previous motion around the definition itself?
I think it's a separate.
It's separate. The previous
Yeah.
motion accepted the definition. This motion
Yeah, this
accepts
is
the definition
separate.
for the board subcommittees and the agency.
So moved.
Seconded.
All in favor?
Aye.
Aye.
Okay, opposed? Great. It is passed.
Thank you so much.
All right.
Thank
Thank
you.
you.
Thank you all. I also just, I should probably thank the rest of the Health Equity Committee members who did put a lot of time and energy, as well as OEI staff, and particularly Maria Castro, who really helped to do a lot of the community engagement and kept us on track and pulled us together. So I just want to honor the work that she did and all of OEI as well. So thank you.
Thank you. So that's the end of our agenda.
Before we leave the topic, I wonder if we can continue to think about how we as a board are going to cement the definition in our own awareness, and that we ask the committee or OHA in general to help us think about what our own developmental path is in this territory. You know, it can be as simple as, you know, let's us include the definition itself on the bottom of every meeting agenda. You know, like that's like step one, you know, in terms of heightening our own awareness. But I'm also thinking about developmental opportunities where we get after some of the belief system change, you know, that is so upstream on the right, on the left side of that continuum, that we can think about it and modeling the way.
So Jeff, I would suggest we put that as part of our items on our planning calls that we have, so that we make sure that we keep that up front. Anything else? Then we are adjourned a half hour early. Wow. Thank you.